So I would start. I think there are 4 or 5 people in the call. So I'm gonna share my screen with you. As I mentioned, my name is Stefano Liberti. I'm a professor of respiratory medicine at the University of Milan, Italy, and I'm a pulmonologist at the Policlinical Hospital in Milan. I will be hosting the session with Professor Soggio from the University of Sassari and Professor Effler from the Humanitas University. And I will give them the possibility to introduce themselves during my short introduction. The job today is to get together and learn something about clinical methodology and scientific publication and writing in the field of respiratory medicine. This is the Future Health Leaders in Respiratory Medicine project. We are leading since several years during the Lung Health Congress. A special focus this year has been dedicated in exploring scientific publications in terms of observational studies, randomized controlled trials, and systematic reviews and meta-analysis. And this will be 3 days together, this morning and this afternoon, and then tomorrow and the day after tomorrow, working together with myself, Professor Soggio, and Professor Heffler in exploring 3 different papers. One is a multi-center prospective observational study, one is a randomized controlled trials, and one is a meta-analysis. As I mentioned, this is not the first time we're doing this, but in 2021, the International Workshop on Lung Health focus on treatable traits has been affected by the coronavirus. So we are not seeing us face to face, but I think that this platform will work really good and will allow us to share some informations and learn from each others as we did over the past few years. And the virtual tools will not limit our passion for clinical research and for the mentoring we did last year and the year before for people coming from different parts of Europe. We were able to get in contact with very closely also after the meeting. So the aims of the program are first to share our competences in designing clinical research, in identifying the right research question, and especially in reading and writing a manuscript. So there are several not very good publications in the literature. So one of the challenges we are expected to face every day is understanding which kind of papers deserve to be put in our desk, and which kind of papers might be trashed because they are not following the right methodology, and the results and the discussion are useless. So the scientific publication is very complex, and there are several insights that we want to share with you that will allow you to be more focused, not only in writing and reading, but also in designing clinical trials. The format will be a sort of study session where we will allow you to go through a specific publication, discuss all together about challenges of the publications, and ask a special mentor support and taking notes and discuss all this during the afternoon with your mentor, make intervention, question, express your opinions, and discuss with the mentor and the colleagues the papers in terms of research questions, in terms of study designing, and also in terms of writing the paper. The day one of the program will be mainly focused on observational studies. And I will be hosting this first day. So let me introduce myself. As I mentioned, I'm coming from Milan. My major interest is in respiratory infections, both acute and chronic respiratory infections. And one of the paper I will share with you is focused on cardiovascular events in patients with community acquired pneumonia. And I work in the Policlinical Hospital, which is a tertiary care hospital in Milan, now mainly on COVID-19. But before COVID-19, we were doing respiratory infections, especially bronchiectasis, NTM, cystic fibrosis, and lung transplant. So this is my background. The day number 2 will be focused on randomized controlled trials. And this is the paper you're going to discuss with the second mentor. I ask him to introduce himself, who is Professor Enrico Effler from the Humanitas Research Hospital and Humanitas University Milan. Please, Enrico, if you can introduce yourself.
Thank you very much, Stefano, and thank you all guys here participating to these 3 fabulous days, as Stefano said. Yes, I'm Enrico Effler. I'm an allergist and clinical immunologist. My personal and research interests are clinical research interests are mainly focused on the respiratory part of.
Angela, posso chiamarti in un secondo?
Sì?
Ok, scusa.
Sorry, no, sorry. So I was hearing Stefano in the background. So I said I'm an allergist and clinical immunologist, but my main scientific and clinical interests are on the respiratory part of allergic diseases. So in particular, asthma. In the last few years, I was I'm really working on severe asthma mainly, and its comorbidities, particularly nasopolymphobia and so on, and of course all the new biologicals that are using now in clinical practice, and those who are in clinical trials so far for asthma and its comorbidities. Tomorrow we will discuss exactly one paper which has been very recently published. It's a randomized controlled study and will be focused on patients with asthma. We will have enough time to discuss this paper as a good example on several aspects on randomized clinical trials. Thank you very much.
Thank you very much, Enrico. The third day will be mainly focused, as I mentioned, on exploring meta-analysis with this paper on multi-drug resistant tuberculosis. And the mentor will be Professor Giovanni Soggiu from the University of Sassari in Italy. Please, Giovanni, feel free to introduce yourself.
Thank you very much, Stefano, for your kindest introduction. Good morning and welcome to everybody. I'm a full professor of medical statistics and clinical epidemiology at the University of Sassari, Italy. And I'm a medical doctor with a background in medical statistics, clinical epidemiology, and methodology of clinical trials, as well as in infectious diseases. On Saturday, we will discuss about the main points on the systematic reviews and meta-analysis, and the articles, as highlighted by Stefano, will be on the treatment outcomes of the individuals with multi-drug resistant tuberculosis. So we will describe the findings of an individual patient data meta-analysis, which was published in the Lancet, and which is the basis of the official guidelines of the American Thoracic Society, the European Respiratory Society, the US CDC, and of the Infectious Disease Society of America. Stefano.
Thank you very much, Giovanni. And now we would be very pleased if you could introduce yourself and just a few words, your first name, last name, where you work, and mainly your major clinical and research interest. So I will stop sharing the screen, and in order for me to have all you on my page, and I will start from Animesh Rai. Could you please introduce yourself?
Yeah, sure. Hello, everybody. My name is Animesh. I'm from New Delhi, India, where I'm working as a consultant, as a pulmonologist at All India Institute of Medical Sciences, which is a tertiary hospital in the national capital region of India. That is, my primary interest is in the field of respiratory infections. We look at, by we I mean our team look at a number of respiratory infections, including tuberculosis, as well as post-tuberculous sequelae, including chronic fungal infections, as well as acute infections like community-acquired pneumonia, as well as ventilator-associated pneumonia in our intensive care unit at our hospital. And I'm very excited to be here. I hope to have 3 days of learning and sharing knowledge. Thank you.
Thank you so much. And then we move to someone who I don't know at all. She's Ksenia Suska. Hi, Ksenia. How are you doing?
Hello.
Nice to see you again.
Nice to see you, Stefano. Dear colleagues, hello for everyone. My name is Ksenia Suska. I'm from Ukraine. I am a PhD student, and the fields of my clinical and research interests are bronchiectasis and respiratory infections. Also I participated in such kind of program 2 years ago in another format, but this year I think it will be very interesting, and thank you for this opportunity to take part in this great program.
Thank you so much, Ksenia. And now we move to Olga Nesterovska. Please, Olga.
Olga, I think you're mute.
Sorry. Good morning. I'm also from Ukraine, and it's also my not first time being involved in this program. Actually, I was in Czech Republic last year, and I'm a PhD student, and my main interest is asthma and COPD. So for now, maybe that's all.
Thank you, Olga. And now we move to Julia. Please, Julia.
Hello, I'm very happy to be to see all of you again. My name is Yulia. I'm also from Ukraine, from small city of western part. I am also a PhD resident, and I also work as assistant of professor of pathophysiology department in medical university. I do research in pathogenetic changes of the lungs in case of diabetes mellitus. So I would be very happy to explore new things and new updates regarding to lung pathology. And I'm very grateful to be a part of such a great event this year.
Thank you so much. Thank you so much, Julia. And nice to see you again. Nice to see you again, Olga. Thank you for joining us in this project again. And then we move to Arun Kontaru, please.
Hi, good evening. I am Dr. Arun from India. I am working as a consultant pulmonologist in Artemis Health Institute. I am also very excited to be here to learn new things, observe how to write and publish an article. Thank you so much.
Thank you, thank you. And now we move to Dharma Prakash Dwivedi.
Hello. I'm Dharma Prakash Dwivedi. I'm Associate Professor in Pulmonology. In southern part of India, we have Institute of National Importance, that is JIPMER. And my interest is in ILD and interventional pulmonology. Thank you.
Thank you so much. And then I seen the on the screen Antonia Satyavati.
Yes, good morning, everyone. I am Antonia Satyawati, a resident in Internal Medicine Department from Indonesia, Universitas Gadjah Mada, and my research interest is in infectious disease, especially tuberculosis. I finished my PhD 2 years ago from the Netherlands, and last year I also participated in the international workshop on lung health, and this year I would like to participate again because it was a very good workshop. Thank you.
So thank you so much. I think we are all we are here. Teresa, just correct myself and if I'm wrong and I'm missing someone else.
No, it's fine. All the people are connected. We could have 2 more participants. If they will access, I will inform you. Thank you.
Very good. So now, now I will be hosting the first part of the meeting. So I think that maybe Professor Sojo and Professor Effler they will be doing their work outside of this call. So before they are leaving, just let me say goodbye to both of them and thank you. And of course, if you can stay here, this would be very much appreciated. But I know you're really busy, so I think I can talk to you later. The process today is I changed my mind actually. So I apologize with Teresa and the public relation, which I thank as usual for their incredible work. And I decided to make a couple of presentation to introduce clinical methodology in general, because no one told me this 15 years ago. So I think that this is a nice way to introduce the job. So my first very quick presentation is mainly focused on the anatomy and physiology of clinical research, which is something interest as an helicopter view, as I mentioned. Just give me your okay if you can see my screen. Very good. And you don't see yourself on my screen, right? You see just my screen. No video.
We see ourselves also.
As well, yeah.
Okay. Okay. Do you see my screen better in this way, or it's the same?
It's okay.
The same, but it's okay.
Okay.
It's quite
very good. So this is the most difficult line we are asked to work moving from the research question to the publication. But at the end of the story, these are the 2 most important messages when we are doing clinical research. The research question is the first one, and it's we might have plenty of research questions in our mind popping up during the day, and most of these research questions have been already answered in the literature, but we don't know, so we need to go back to the literature and study a little bit better. Some other research questions are not in the literature, so we might want to explore them. Some are nice and feasible and good research questions. Some other one are not very nice or maybe are not feasible. But whatever we are going to do, our final goal is the publication. I want just to share this slide with you because when we start doing clinical research, we always want to have very clear in mind that our final goal is to share our findings and our results with the clinical and research community. And we can do this only by a publication, either an abstract or a poster, much better an article. So if we are doing research per se without reaching a publication, someone could think that this is completely useless because this is good for ourselves, but this is not good for the clinical and the research community. So this line should be done from the beginning to the end. I understand that some of our project might die at the beginning of this line, at the middle of this line, or even close to the publication. But I would like to have you all agreeing with me that we should pursue the publication in a journal. If we have this clear in mind, then we should also think at the beginning, what are the kind of journal where we can publish our findings. Although we don't know if we will be able to have good results or even the results we are expecting, but we should have always the publication in our mind during this pathway. So the first step after having a finer research question would be to write the study outline. So this is the first step, and I would strongly recommend you to share this first step with other colleagues, expert in the field, expert in the methodological field, statisticians, because the most important challenges might happen in the early phase of the design of the process of clinical research in the study outline. Then we need to write the study protocol. And this is the heart of our clinical research, because if the study protocol is very well written, methodologically especially, then who cares about the results? Because the results could be positive, could be negative, but the important thing is that the study protocol and the methodology are the correct one. Usually we also participate in multi-center studies, so we need to have a sort of agreement with all the other principal investigators about the terminology we need to use during the process of clinical research. So we need also to write a study manual that can explain what is the definition of hypertension, for example, or the definition of disease severity. And this is crucial because this will serve to reduce the possible bias in enrolling patients and in enrolling and in collecting the right variables. Then we need to perform the study. Not easy, but this is what we usually think as doing clinical research. We are going to analyze the study results, and then usually we are trying to better understand the results through an abstract or even a poster, and then we expand the poster or the abstract into a major publication. So we need to write the manuscript. So all these different steps are crucial in order to have our effort, starting with the research question, finalized with the publication. Each step has a special law, rules we are supposed to know, and in order to increase the quality of our process. First of all, when we are talking about research in general, we want to create new knowledge. This is our first goal. When we are doing biomedical research, we can create this new knowledge into two special fields. The one is the basic research, where people like biologists, for example, are involved on the lab in order to produce a special basic findings. They are working with cells, they are working with interleukins, they are working with microbiome, gene, etc. In order to generate new knowledge in this specific field. We also know clinical research, which is the generation of new knowledge, mainly working with patients in terms of risk factors, outcomes of the patients. So 30 years ago, these two aspects of the research were actually separated. But now we know that in order to actually improve the knowledge, we need to combine both basic and clinical research and explore a specific topics in a multi-phased way. Another important thing we should always remember is that, for example, if we want to work on ILD, on diffuse parenchymal lung disease at the field, we should be aware that there are patients in the universe with diffuse parenchymal lung disease. And when we are doing clinical and translational research, we are just taking a little piece of this population. We extract this population and we are working with them. So we are doing clinical research and basic research on them. We are coming out with different findings in order for them to be generalized for all the patients in the universe. So this is a very, very, very important, because this will introduce a special concept, which is the generalization problem. The generalization means that we want our findings be suitable for the majority of the patients with that specific disease. So for example, if I study Haemophilus influenzae in pregnant females coming from a special town in Milan, from 18 to 19 years of age, and Caucasian. Okay, this is an interesting population, but is not very generalizable among all the patients with pneumonia. The second aspect is that when we are doing clinical research, we might end up with a publication. And it's very important to remember that the findings of this publication in the field of clinical research should be always have a clear impact in clinical practice. So this is what we call the so what of the findings. Once our findings have a clinical impact in our daily practice, this is the best way to generate a new gaps, to generate a new research question, and to go back to our methodology in order to perform a study, to have good findings. And this is the way as we improve medicine through clinical practice, clinical research, and guidelines. As I mentioned, now we have not only basic research and clinical research, but we might also have population based research. All these three kinds of research are overlapping in what we call translational research type 1, when we are applying basic science findings from the lab into a clinical study of patients. Then we might have translational type 2, when we are applying the findings of the clinical study to improve healthcare practice in the community. We might want to have a very big project like the Horizon 2020 or a very big international highly funded project that are integrating all basic clinical and population research. Let's think about the COVID-19 vaccine. COVID-19 vaccine would be a perfect example where basic clinical and population research could be integrated. So in 1 year, a big project went through the development of a vaccine, and this is mainly done on the lab, testing through phase 2, phase 3 clinical trials. And then we might want to follow up the vaccination campaign and the long-term outcomes of people who underwent COVID-19 vaccination in the community. So big projects usually integrate basic, clinical, and population research, with the final aim to get as far into the community as possible, and inform not only the clinical community, but also healthcare professionals, stakeholders, regulatory agencies about these results that might change the way as we do medicine. Another way to see the same topic is on a sort of pyramid figure, where we have basic research, which is not only lab, but also is animal research, animal model research. Then we move to clinical research, and then we move to healthcare research. So today and tomorrow and the day after tomorrow, we will be mainly focused on clinical research. There might be some, we will be able maybe to touch a little bit basic research and some translational T2 population basic research, but we will be mainly focused on the clinical research. So let's talk about diffuse parenchymal lung disease as an example. We want to explore a specific problem on a patient with ILD. Patient in the universe, a lot of patients. We want to plan a study to answer a specific research question because there is a lack of knowledge. Lack of knowledge is the major driver of our clinical research. And from the lack of knowledge, we develop a research question. The research question should be considered very deeply. Because there are specific characteristics of the research question that can give you the green light to move from a research question to the development of an outline. These criteria for a good research question are usually defined as with the acronym FINER, F as in feasible. So the research questions should be feasible. So we need to think about the adequate number of subjects. We need to think about the adequate technical expertise. The research question should be affordable in time and money. And we should have a clear way in mind to reach our scope. The I, as in interesting, explore the fact that the research question should intrigue the investigator and our own friends. So maybe if I have a nice question on what is the best, should we treat pneumonia with an antibiotic or not, maybe this is not interesting. So I go to my colleagues and say, do you think that this research question on exploring the use of antibiotics in pneumonia, yes or no, is interesting? Then my colleague will say, are you crazy? I mean, we already know that that we should give antibiotics in a patient with community-acquired pneumonia, and we have plenty of literature supporting this research question. So the research question might be feasible, but is not interesting. And also, the research question should be novel, Should be novel in terms of confirming previously published findings, refuting or extending previous findings. So usually we think that good research is a research of something which is completely new. Actually, this is not true, because we always want to be the first to discover something, but it's very, very important also to confirm and to publish confirmatory results, because of the generalizability question I just talked to you about. So publishing, doing research and publishing papers on confirmatory results done in a different setting with a different patients are very, very important, because guidelines are waiting for these confirmatory results. And this is the only way to have these findings into our clinical practice. The E of FINER stands for ethical. All the studies, prospective, retrospective, observational, interventional studies should undergo an institutional review board approval. This is very important because there might be some feasible, interesting, and novel research questions which are not ethical. So ethical is something that should be always, I think it's the most important part of the methodology. And the IRB approval should be always there. And finally, R stands for relevant. Relevant, we need to be sure that once answered, our research question will be able to advance scientific knowledge and will be able to influence and change practice guidelines and health policy. This is, as I mentioned, the so what of our study. The source of the research question. So there are several ways as the research questions might pop up in our mind. First of all, literature. So we need to read and read and read daily a lot of articles because only reading we know if is a research question has been already answered, or if the research question actually is novel, is interesting, is relevant. So reading literature is the most important thing we should do as a researcher. The second point is prior studies. So for example, I'm conducting a study today on the use of antibiotics in bronchiectasis, and I find that they are useful. Then, according to my previous findings, I want to move to another study looking at duration of therapy, for example, of antibiotics in bronchiectasis. In order to put one brick of the wall after one, in order to build up the wall of the knowledge. Meeting, very important, like this one. We are doing through the web, but also face-to-face meeting. I think that the most important part of a meeting is not just listening Stefano Aliberti giving a lecture on bronchiectasis, but is meeting people, having coffee with people, discussing with people, sharing experiences, comparing my way to do research with yours, and this is the most important way to learn. And finally, but last but not least, is patient care. When I'm doing my clinical practice and I'm following guidelines, but I cannot find an answer on the guidelines or in my standard operating procedures on how to treat a patient, this is the best way to develop a research question. The research questions are usually classified according to 4 major areas of interest. We might have a research question focused on etiology. So these are the kind of research questions which explore risk factors for a specific disease. research question want to determine cause-effect relationship among risk factors and disease. So this is the etiology kind of research question. The second is the prognosis kind of research question, when we want to evaluate the natural history of the disease and when we want to identify prognostic factors. The third research question is mainly focused on diagnosis. So what we want to do is to explore the accuracy of a specific diagnostic test. For example, D-dimer in making the diagnosis of pulmonary embolisms. And finally, therapy. So we want to test an intervention to evaluate both safety and efficacy of this intervention in our patient. Remember that interventions is not always equal to drug, but intervention could be prevention, could be education, could be rehabilitation, could be physiotherapy, could be implementation of specific standard operating procedures. So all these are interventions. Now, when we look at the literature, we can see that the majority of the original articles are mainly focused on diagnosis and therapy. In general, I'm not talking about respiratory medicine, I'm talking about general. So few articles are focused on etiology and prognosis. However, to be sure that we are treating our patients in the best way, we need to have informations from all these four major areas: etiology, prognosis, diagnosis, and treatment. Another important point is the so-called pyramid of the evidence. I think that it's important for me to show you this pyramid, but it's also very important to me to discuss with you all the different steps of this pyramid. So usually we think about preliminary studies, animal models, in vitro lab studies. Then we move to case report, one patient, to case series, 2 or more patients, to a sort of case control studies. Then we will have cohort study. Then we have randomized control trials. And then finally, we have systematic reviews and meta-analysis. This is the pyramid of the evidence, but this does not mean that systematic review and meta-analysis means more than a case control study or an in vitro study. But all these studies are important in the field of the clinical research because they inform the research community and the clinical community about different aspects of the research during a pre-specified timelines. Of course, that a very well done multi-centers, very large, double-blind, and blah 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 randomized control trial will give us more information specific on an intervention than a cohort study. However, no randomized control trial can inform us on risk factors for mortality in a community-acquired pneumonia more than a very well done cohort study. So each kind of study should be selected according to the right research question we want to address. So for example, for etiological research question, we don't need a randomized control trials. While for an intervention research question, we might want a randomized control trial more than a cohort study or a case control study. Another important issue that you are going to explore with myself and Professor Soggio and Professor Effler today, tomorrow, and the day after tomorrow is the so-called selection bias, how we can identify the right study population. So we know that in the world, we might have our target population, for example, patients, adults with interstitial lung disease, which is our target population. Then there is an accessible population. So among all the patients with diffuse parenchymal lung disease, we have been selected according to clinical and demographic characteristics. We have an accessible population in terms of where and when. So in terms of geographical and temporal characteristics, we select a subset of patients within the target population who might be available for the study. For example, patients with ILD, diffuse parenchymal lung disease, living in Milan during 2008. And then we have the study population. So the study population is a specific population within the accessible population that are going to participate in the study. For example, we have patients refusing to give informed consent and patients who do not want to enter a specific study. So they are accessible population, but they will be not our study population. All these should be always very clear in our mind, because these three circles affect the generalizability of our results. And finally, this should be my last slide, is about medical writing. We will try to integrate some methodological issue with some medical reading and writing. So I will talk to you deeply in few minutes, but as you mentioned, we have discussed about the problem, the research question, and this is the first part of the paper, the introduction and the objective. And then we have discussed about population methodology, study design, study outcomes, study population, and so on. So this is in the materials and method section. We want to have the findings, what we found from the study. These should be put in the results section. And finally, in the discussion and conclusion, we should discuss our results, but the most important thing is the so what and the who cares part of our findings. We should prove that our findings are important because they might change something, and there are some people outside, outside very far from where we work, that might be very interesting to those findings and want to replicate those findings and want to integrate those findings in their clinical practice. So this is the story. This is the story. It's a lot of things to do, but I think that it's very important that we have an agreement on all the different steps of this process. Now I stop here for a few minutes, and I would be happy to answer to your questions and to share some comments with you and stuff like that. Please, you can easily switch your mic on and tell me what you think, if you have questions for me, or this is what you guys are doing daily.
Stefano, I have a question about the study population. How do you define how much patients should you include into your study?
Okay, so the sample size calculation is a crucial aspect when we design clinical studies. So first of all, there are some design where the sample size should be there 100%. And this is the case of randomized controlled trials. So the reason why we need to think about the correct sample size is because to test our hypothesis, 2 patients might not be enough, while 3 patients might be, and 6 patients might not be enough. Might be too much, too many patients. So there is a right number of patients that we should include in our randomized control trials in order to test the specific hypothesis. How we can do that? In order to do that, we need to read literature. So we need to have a clear idea about the effect on the endpoint for the control group. We already know from the literature or from our clinical practice. And then we need to have an idea about the difference in terms of the effect in the case population. So, for example, antibiotics in pneumonia, for example, antibiotic A cure pneumonia in 80% of the population. These are the controls. I want to test the antibiotic B, and according to basic studies, pilot studies, and my clinical practice, my hypothesis is that the antibiotic B will cure pneumonia in 99% of the patients. So this difference, okay, and all the other calculation we are doing will give you the right number of patients to be included in your randomized control trials. Now, also for observational study, we might want to have a sample size, the so-called not all the study, not all the same observational studies have the same power in order to answer a specific hypothesis. So we usually discuss with our statisticians in order to define the correct sample size to be included, in order to be sure that we are not that our study will be not underpowered to answer that specific research question and that specific hypothesis. This is not mandatory for publication, but is a high quality research that we are suggesting. In case of observational studies, but also in case of randomized control trials, we should have a clear endpoint in our mind, okay? Not exploring if drug B works, but we want to have a specific endpoint, rate of 30-day in-hospital mortality, okay? And we want to have, in this case, a rate for drug A already known in literature, and we want to have a rate for drug B that we are hypothesizing for our study.
Stefano, I have also the question for you. You said when we put research question, we every putting of research question starts from literature survey. So I would like to ask you, how can we, what is the best database for us, and what articles we should rely on for this?
Julia, for the sample size, you mean, or in general?
For clinical research. I mean,
for clinical research. Oh. So usually, when you are doing important research and you are deciding to design a very important study, you should always go for a systematic reviews of the literature. Okay. I don't want to anticipate what Professor Soju will tell you in 2 days, but there are specific guidelines which are called the PRISMA guidelines to design a good systematic review. The PRISMA guidelines are important because they are walking you through the correct systematic review in terms of identification of the right language, identification of the right setting, identification of the right time period, identification of the right database you need to search, always with an endpoint in your mind, And then the systematic review could be very broad, or could be narrow, with some pro and cons. So huge systematic reviews are very, very accurate, but they might be taken too long in terms of timing, and this could be not feasible for you. Very, very small and quick systematic review maybe are feasible, but they are not accurate. Usually there are English language is always there, but if you can also include French, Spanish, or Portuguese or whatever, if you have people that can translate your language, it's much better. The time period is very important and should be selected according to your endpoints. For example, it's useless if I do a systematic review on COVID-19 vaccine if I start 1980. Make no sense, right? Okay, I would start 2019. While if I need to do a systematic review on antibiotics in pneumonia, maybe I want to go back to, I would say, 1970, 1980, or whatever. So the setting, the study population depends always to your endpoints. But I don't want to anticipate Professor Soju, because he's really much better than me in discussing this with you.
Thank you very much for your answer.
So, Dr. Aliberti, I think, I mean, if I got the question, please, I mean, correct me if I got the question wrong. I think what Yulia was talking about was which source do we look up when we are planning research? I mean, so normally we look up a Cochrane systematic review followed by PubMed, Embase, and then Google. Is that what you follow? I mean, I'm sorry.
Okay. I got it. So, you can search several databases. Usually there are some I would say mandatory databases that we are expecting as reviewers. You search for your systematic review, which are PubMed, for example, or Embase. I'm not sure that Google is the first database I want to see in a published paper, but all the different databases have pro and cons, and I don't want to tell you something I can justify. So I would keep this question to Giovanni, because Giovanni Soju knows the difference among all the different databases. When I do a systematic review, I ask him to write the correct study design for the systematic review for me. So I don't want to tell you something I'm not really 100% into.
But what is your favorite database for you?
Usually 90% of my literature search are done on PubMed.
So I had one question. So you talked about preempting the journals before we start research. So I mean, that is something which clearly I don't do, because sometimes I feel that the results of my study ultimately influence which journal I would be trying for. But at the same time, as we are talking about journals, is it also a good idea to think about authorship initially when we are thinking about the study? Because a lot of people tell me that you should always get the the sequence of authorship right. So is that a common practice, a good practice?
So Animesh, can you reformulate your question while I'm trying to give you a polite answer?
Okay. No, so if you're working in say a multicentric study, right? If you're working in a multicentric study, so there are multiple authors involved. So I personally have not done any multicentric study, but what I mean, some of my colleagues and seniors have done it. So they have said that when you're doing a multicentric study, it's a good idea that when you're conceptualizing the study and when you're reaching out to your colleagues and your compatriots, you should think about the sequence of authors. So, who's going to be the corresponding author and who's going to be the first author. I mean, probably it's a silly question, but I thought, since, you have so much of experience, probably you'd be the best guy to answer this.
Okay. So, so let me tell you this. If you don't want to make a mistake, let me share my screen with you. If you do not want to make mistake, okay. If you don't want to make mistake, you need to be clear with all the investigators you are involving about the authorship from the beginning. So when you send them, when you send the protocol to them, I would clearly state in the email or in the protocol what are the rules for authorship. The second thing, if you don't want to make any mistake, refer to the International Committee of Medical Journal Editors that clearly are defining the rule of authors and contributors. Who should be in the author list? Who should be in the contributors list? Who should be in the acknowledgement paragraph? So there are strict criteria. So this is the website. These are all the website. This is the website. If you see who is an author, the ICMJE recommends that authorship should be based on 4 criteria. Can you see my screen, or do you want me to enlarge? Can you see this?
Yeah, okay. I can see it.
So 4 major criteria. So a substantial contribution to the conception or design of the work, or the acquisition, analysis, or interpretation of the data, and drafting the work and revising it critically for intellectual content, and final approval, and agreement to be accountable for all aspects of the work in ensuring that questions related to the accuracy and the integrity for any part of the work have been investigated and resolved. So these are the 4 criteria that should all be present to define an author of the paper. So for example, if I have a biologist who is working in the lab and is just doing ELISA, okay, he's not, I can acknowledge him or her for his or her contribution, but he or she does not reach the criteria for the authorship, because all these 4 should be included. I understand. I share with you maybe some ideas about the acquisition, analysis, interpretation of the data of the work. This is a gray area, but I would always refer to these criteria.
Thank you.
Did I answer to your question?
Yeah, sure. Do you also sort out the sequence also? I mean, this is about the qualification for authorship, but once you have decided that these are the authors, do you also upfront decide that this guy is going to be the first author, the second, the third, and fourth? That's how it happens. That's how it should happen.
Yes. So the list, the list. You want me to answer about the list, right?
Yeah, list and sequence. 1, first, second, third.
So there are 3. Okay, there are 3 major position, Animesh. In the Animesh is your first name, right? Or Ray?
Animesh is my first name.
First, Animesh. There are 3 major positions in the author list: first author, last author, and corresponding author. Okay. So usually the first author is the one who did all the job. Having the research question, defining the outline, putting together the protocol, performing the study, blah, 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 blah. Is the first author. Usually is the one who is, let's say, organizing the work. The last author is the senior one. So is a senior author who reach the 4 criteria I just mentioned, who control the quality of the job, you know, as well as the corresponding author, who is the one who had the data, and should be the one who is organizing the job. Then you might have 2 first author, 2 last authors, and then all the other authors in the middle. Very difficult to define the positions. I would suggest you to go on alphabetical order, for example. This would be one criteria, or in according to the number of patients they have enrolled. This is another criteria. But I think that after besides these 3 positions, all the other positions are pretty much equal, you know, Animesh. So there's no big differences. Usually you discuss about these 3 positions.
Thank you so much.
So Fatima, did you have a question for me?
Thank you. Because I just want to ask about something about ethical approval. Yeah, so we don't apply treatment on a patient. So do we need ethical approval?
So Fatima, in order to be sure, I would always go for an ethical approval for any kind of study you are doing, also for a retrospective cohort study, because this is what the journal are. This is what the journal are asking us. Okay, when we are submitting the manuscript, all the journal are looking for an IRB approval. So let's start from the beginning and let's start working always with an IRB approval done.
Sometimes we don't have board specialized in this that. So when I work in a university, I can apply for this ethical approval from the university. But if I work in lab,
Fatima,
for example.
Fatima, there is some noise behind you. I cannot hear you very well. Can you write your question in the chat?
Yeah. Okay. I do that.
Okay. Any other question for me? Okay. So let's wait. Let's wait for Fatima question, and then we move on. Chat. Okay, so let's wait, Fatima, and then we move on. In some cases, there's no board for ethical approval. For example, in university, there's a specialized board for that. Yes, this is the, I understand this, Fatima. If you are working in a lab, I don't have any experience about that. I don't do pure basic research. So I don't know if all the basic research project should undergo an ethical approval. I don't know that. I think so, because actually you are working, maybe if you're working on human samples, like blood, urine, BL, or whatever, then there will be patients who gave those human samples. So it's important to have an ethical approval. But for the rest, I cannot answer your question, Fatima. Sorry. So let's break for 5 minutes, 5 minutes in order for me to get some water, and then I will be here in 5 minutes, and we will do the second part of this morning section. Okay. So I think we can start. Can we start? Yes. Okay. Very good. So now my task would be to introduce you to the magic word of the observational study. As you can see from my screen, there are the observational studies, along with the experimental study, are usually characterized under the so-called primary research. Primary research is crucial, is where everything begins. Pure data, pure research, either observational or experimental, interventional. Then we know that there is the so-called secondary research. Secondary research means systematic reviews, evidence-based guidelines, HTA reports, economic analysis, or decisional analysis. So here we are not doing original data like in the primary observational and experimental research, but we are reanalyzing the data in order to move into a specific recommendation. And then we have the so-called, and then we have some traditional resources that are not systematic reviews, but are narrative reviews. So, for example, I want to talk about pneumonia, but I'm going to select the papers I like to put together this review. This is a narrative review. Whereas if I want to do a systematic review on antibiotics in pneumonia, where looking at the impact on mortality of antibiotics in pneumonia, then I do a systematic review on that specific endpoints, and I need to cite all the different papers I have identified through that systematic reviews. Then I have editorials, I have expert opinions paper, perspective. So these are the so-called traditional resources. When we are opening a journal, we are finding primary research papers, secondary research papers, and traditional resources papers. Okay, all these papers are important, differently inform the clinical and research community, but usually the most important evidence are here in the primary research. I'm going to talk to you about observational data, observational studies. So usually the observational studies are divided into two big groups, the so-called descriptive studies and the so-called analytics studies. Under the descriptive study category, we have case report and case series. Under the analytics study category, we have case controls, cohort study, with or without parallel cohort, and then cross-section study, or the so-called punctual design. Okay, now each of these descriptive or analytic studies is able to answer with a different degrees of confidence and evidence to some etiological-based, diagnosis-based, prognosis-based, or treatment-based research question. For example, you can publish a case report or a case series looking at etiology or diagnosis or prognosis or treatment. Usually, the descriptive studies are retrospective. Let's move to the analytic studies. In the analytic studies, we have case controls that are retrospective, and usually the case control study should be designed only to answer some etiological-based research question. Cohort study could be either prospective or retrospective, And usually they are designed to answer a prognosis-based research question, or if you can have also a parallel core, you can answer an etiological-based or even an intervention treatment-based research question. Of course, the quality of evidence and the confidence in evaluating the results of a parallel analytic observational studies on treatment are less than the randomized controlled trials. But you can do this. For example, this is the case of the COVID-19 situation in the first months when without randomized controlled trial, we were publishing observational studies on treatment of COVID-19 that after that have been confirmed or not or refused by good randomized controlled trials. And finally, we have the cross-sectional study. They are called diagnostic study. They are not retrospective. They are not prospective. They are, let's say, punctual, like a picture of a photograph. So they are not. They are neither retrospective nor prospective. This is just a punctual evaluation of the situation. And the cross-sectional studies are usually used to answer a diagnosis-based research question. Now, this slide is very important because you can understand in terms of observational design what are the best study you are supposed to use in order to answer either etiological or prognostic or diagnostic or treatment research question. Now, I stop here for a moment and I will give you the possibility to answer some questions because this is important. Each research question might have a specific study design, a perfect study design, an optimal study design, or a suboptimal study design, okay? Is this clear to you?
Yes, it's clear.
Olga?
Yeah, for now, yeah.
Okay. Animesh?
Yeah, it is clear. Thank you.
So let's say that when myself as a section editor of a journal or even a reviewer decide to reject or to send to reviews a paper, usually use this kind of criteria. Okay. So for example, if you are sending a nice paper on anakinra in COVID-19, and this is a case studies, a case series, I reject this because the gold standard to explore anakinra in COVID-19 is a randomized controlled trials because it's an intervention. So if this is the first study ever, I might want to accept as a case series. But if people already publish observational study looking at outcomes of people on anakinra with COVID-19, I don't want to publish this because the quality of the evidence, the confidence is very low. Very good. Now, one of the study I'm going to discuss with you is the one you can see on my screen. I decided to choose one of my study, not because I think I'm the best in the world, but just because I can answer to your very tricky questions you are going to ask me during the discussion of this paper. So this is a study we published a few years ago in Community Acquired Pneumonia, looking at cardiovascular events. And the job you are supposed to do today is to read this article and try to divide this article in different sessions and identify the introduction part, the objective part, and all the different part of the methodology, results, and discussion. So to sum up, this is an international multi-center observational prospective study done in Italy and Switzerland a few years ago. enrolling 900 patients with community-acquired pneumonia, looking at cardiovascular events, acute myocardial infarction, and other cardiovascular events in this population of patients in order to understand their prevalence, risk factors, and impact on mortality. Now, this study has strength and a lot of limitations and some mistakes. So what I want you to do is to go through the study, and then when we will be back together this afternoon, to tell me if the criteria for the perfect observational studies to be published have been reached or not, and what are the limitation from a methodological point of view. Now, how you can do that? For observational studies, there are precise guidelines. Now, if you go on Google, okay, no, not this one. Yes, if you go on Google and you put strobe statement, you will download the guidelines for the perfect observational study. This is the strobe. Strobe is an acronym for strengthening the reporting of observational studies in the epidemiology. So don't go through, so the strobe is divided according to case cross-sectional studies, case control studies, cohort studies. So for the purpose of the job we are going to do today, just download the PDF of the cohort study. If you download the PDF of the cohort study, you can see that, and you have this in your left hand, and you have my article on your right hand. You can check if everything that is present in the checklist of the strobe statement for the cohort study is done in my article, or if it's not done. So the checklist is title and abstract, introduction, methods, results, discussion, founding. Okay, so this is a nice way to work for you to learn from reading how you are supposed to design a study, a cohort study, and write an observational study. Okay. Now, let me give you a general introduction now about the writing, the medical writing in general. Can you see my screen with a PowerPoint presentation?
No PowerPoint, no. No, we can't see. Can't.
At all.
So I'm experiencing some technical issue. Can you see my screen now?
Yes.
Yeah.
Okay, very good. So all the papers usually I have follow the IMRAD format. The IMRAD format is introduction, material and methods, results and discussion. In the introduction, in this fourth session, there should be a clear a clear structure, a clear anatomy. So the introduction is usually done to help the reader to go from what we already know in the literature to the objective of your study. Usually we start from a background, which is the first part of the introduction. Then we move to the second part of the introduction, which is the generation of the problem. And then we go to the objective of the study. the background identify the importance of the field of research. Pneumonia is the first killer in the world. A lot of people are getting pneumonia. Pneumonia is bad. Pneumonia is treated with antibiotics. Pneumonia is treated with macrolides. Pneumonia is treated with azithromycin and clarithromycin. This is the background. Then the problem, we need to generate a question. So azithromycin and clarithromycin are both macrolides, but they are different in terms of PK/PD, in terms of blah, blah, blah. We don't know if clarithromycin works better than azithromycin in treatment of pneumonia. And then we move to the objective of the study. The objective of the study is to evaluate the safety and efficacy of azithromycin, of clarithromycin in comparison to azithromycin in the management of adults with community-acquired pneumonia. So this is the introduction. So we go from the known to the unknown. When I act as a reviewer and I read the introduction, I usually want to understand if the authors have built in a logical way the problem. Then I want to, I see if the problem is well articulated. I want to see if the literature has been properly analyzed. And I want to see if they used the references in the right way to support their statements. And finally, the objective, I want to have the hypothesis of the authors clearly in the introduction, the objective that should be clear, should be concise, should be complete. All these are criteria that I'm using as a reviewer when I evaluate the introduction. Then we move to the material and methods. So we are talking about observational study. We tend to have in the outline the study design, prospective, multi-center, observational, cohort study. Then we need to have the subject, enrolling patients with community-acquired pneumonia. Then we should have the setting in Milan. Then we should have the time period between 2020 to 2021. Then we should have several other important aspects like ethical approval, consent. And then we go for different study definition, outcomes definitions, endpoint definitions, study group definitions, and then the statistical analysis. So for example, in the study definition, we should put the inclusion criteria and the exclusion criteria. We should have all the predictive variables, the outcome variables, and the confounding variables very clearly stated and defined. We should have the quality control, which kind of procedures we put in place to monitor the data collection, and then the statistical analysis, including the sample size, especially for the randomized controlled trials. The material and methods should be written in past tense. When I act as a reviewer criteria, the first thing, and this, trust me, is the most important thing, is the research design appropriate or as optimal as possible for that specific research question? If there is no matching between the research question and the appropriate study design, I'm not reading the paper anymore. I just trash the paper. I don't care about the results. I don't care about the discussion, because the methodology is wrong. When I act as a reviewer, I always read the last part of the introduction where the objective is, and then I go through the methodology. That's it. At that point, I decide if the paper should be trashed or should be sent to reviewers. I don't care about the results. I don't care about the discussion. I care about the methodology. Does the research have internal validity to address the question rigorously? does the research has an external validity? So this is important because you can publish the best results ever, but if these results cannot be generalizable to subject beyond your research situation, this research paper could be useless. And finally, material and methods are clearly defined and sufficiently detailed to permit the study to be replicated. So this is easy. Think about this. If you send your material and method section of the manuscript to myself in Milan, okay, can I do exactly the same study following your material and methods without having to call you because I did not understand what is the definition of hypertension, what is the definition of study groups, and so on? So this is the best review criteria to understand if your material and method are done in the proper way. The results should be written in past tense. The outline should be always be consistent with the outline of the other section of the paper. So if I wrote about the study population in the material and methods, I need to find the study population here in the results. If I wrote that I evaluate mortality in the material and methods, I need to have the mortality results in the results. If I wrote that there is a secondary endpoints on hospitalization, I need to find the results of hospitalization in the results section. So this is very, very important. The IMRAL method is of course used not only for the manuscript but also for the abstract, and is also used for the poster presentation. The results are the way to organize the data is the same. The results usually we use a narrative description of the data and we use text. We use tables. They should have titles and footnotes, figures with legends, and then a balanced descriptive and analytic results. The most important thing is that results should be presented without any interpretation. This means, however, notably, interestingly, should be avoided because you are interpreting the results. So the results section should be without any kind of interpretation. Put there the findings very well organized. When I act as a reviewer, I see if the results are organized in a way that is easy to understand. I understand if I try to understand if tables and figures are used judiciously, if text, tables, and figures are among them consistent, if the amount of data are even sufficient, appropriate, or even too much, or useless, if there is interpretation or implication of the data presented in the result session. I don't want this, because all this should be done in the discussion. Now, the discussion, the outline is answer the question, what are the major findings of your results? You need to, among all the results you have presented in the results section, in this specific paragraph, you need to tell me what are the major findings. Then implication of the results, possible mechanisms of your findings. You need to correlate your findings with all the other studies published in literature. You need to tell me what are the limitations and the strengths of your study. Access generalizability, suggesting implication for research, and then a conclusion. So for example, we write this in the present tense usually, and we say this study shows that mortality in pneumonia is 90%. One important implication is our findings can be due to our data either support or contradict the previously published literature. Strength and weakness of the study are, and so on. So the discussion, when you read a discussion and when you're writing a discussion, you should always identify this paragraph in the article. As a reviewer, I see if the conclusions are clearly stated, if the interpretation are appropriate. We don't want an over interpretation of the results. An alternative interpretation should be always considered. If you are discussing something that is not present in your results, this is possible. If you offer clinical and research presentation, and the most important thing is that you should be able to state exactly what are the limitations of your study in terms of methodology, in terms of results. This is very, very important. So the manuscript presentation, the text should be well written, good English, easy to follow, appropriate vocabulary, no complicated language, very simple and short sentences, very well organized, and all the citations should be complete and accurate. Usually I think that poor presentation of a manuscript reflects poor content. The type of the manuscript I usually use, ask my fellows to do in a double space, Times New Roman, 12 characters, with all the different titles. Number pages should be done consecutively from the title page, and you can also use subtitles to identify, for example, this section of the discussion. So you can have subtitles for the answer to the question, subtitles for the implication of the results, and then all these subtitles will be deleted once you are going to submit the manuscript. Okay, so this is a very short. So this is a very short overview on the manuscript preparation. I hope this is useful to you. And now, if we go back to my article here, you are supposed to read this in the next 2 hours and identified in the introduction, in the material and methods, in the results, and in the discussion, all the different sections. You are supposed to act as a reviewer, and you are supposed to tell me what are the major limitations of this study in terms of methodology and of the manuscript as I wrote the manuscript. Considering the Strobe guidelines and the Strobe statement checklist you have downloaded from the Google, okay? Is this clear to you?
Yes, clear.
Yes.
Yes, it's clear.
So let's, what we can do is to get together this afternoon. Okay, so let's do this. Let's do this in 2 steps because I like this very much. So let's do a first step from 2 p.m. Central European Time to 3 p.m. Central European Time. You guys get together without myself, without me, on this platform, and you discuss among you what are your impression about the article and so on, and mistakes, limitations, and blah blah blah. Then I will be joining you at 3 p.m. Central European Time, and during 1 hour from 3 p.m. to 4 p.m. one of you will share his or her screen and will show me what you guys have produced during the 1 hour job from 2 to 3 p.m. Okay, maybe if you can put together a PowerPoint you can share with me with the strength and the limitation of this paper. If there is something missing from a methodology point of view, and if there is something missing from a result presentation and a discussion point of view, and then we can discuss from 4 p.m. From 3 p.m. to 4 p.m. and then at 4 p.m. we will end this session. Okay, do you agree?
Okay.
Any question for me?
So just do we meet in this platform itself at 3 o'clock? I mean, when we are discussing it among, sorry, at 2 o'clock?
Yes, I would say you can start working alone. You can start working alone from now to 2 p.m. And then at 2 p.m. you meet in this platform and you share your comments and stuff like that. There is someone who wants to lead the discussion between 2 to 3 p.m. among you? Some who want to volunteer for that?
I will, if it is okay with the others. If it is okay with
Animesh, thank you so much. Oh. So guys, don't kill my paper because it's already been published, okay? And then you're gonna write a nice correspondence letter to the editor saying, what the hell are you doing? You accepted this bullshit. So don't do that, please. Be nice with me, okay? I was young at that time, so a lot of mistakes.
Okay.
Yeah, also young.
Yeah.
Okay, you take care, guys. Bye-bye. You take care.
Bye-bye.
See you. Bye.
Bye-bye.
See you.
Bye-bye.
Just 1 second. Just 1 second. So it's what is the Central European time now? Is it 1 o'clock?
What time is in Europe now?
It's
I suppose 1
1
p.m.
1 p.m.
should be.
Okay, so 1 hour later we are meeting, right? 1 hour.
Yes.
Later.
Yeah, exactly.
See you then. Thank you.
See you.
It's a little complicated, all tied up, no more love, and I'd hate to see you waiting. Had to have high hopes for a living, shooting for the stars when I couldn't make a killing. Didn't have a dime, but I always had a vision, always had high hopes. Had to have high hopes for a living, didn't know how, but I always had a feeling I was gonna be that one in a million. Always had Mama said, something for oddities, stranger causes. They never wanna be the winning the novelties that don't ever change. We wanted everything, wanted everything. Stay up on that rise, stay up on that rise, never come down. Oh, stay up on that rise, stay up on that rise, never come down. Mama said, don't give up, it's a little complicated, all tied up, no more love, and I'd hate to see you waiting. They say it's all been done, but they haven't seen the best of me. So I got one more run and it's gonna...
Good afternoon. I'm Francesco Blasi. It's my pleasure to welcome you to the 8th International Workshop on Lung Health, Treatable Traits, a Look Forward. We started this adventure some years ago in 2013 in Monaco, and every year we have a face-to-face meeting. This year it was absolutely impossible to have a face-to-face meeting, and we decided to have a virtual one. However, I think the success of the edition will be great because we have more than 350 participants and from 57 different countries. So people coming from really all over the world, and stay with us. And we try to, I hope we will have a very nice meeting, working together, trying to have the best interaction possible, even if we are on a virtual edition. Hoping that in the next future we can have a face-to-face meeting, but certainly we try to have a good meeting also in this case. I think the treatable traits is a concept that is clearly debatable, and this is the why we decided to have this year this title, just to look forward to the role of treatable traits, if it's a possible way to manage disease, or it's just a name that means nothing. So we will discuss this, And also we will have the opportunity to have some look to different diseases, including COVID. And with this, I really hope the meeting will be, you will enjoy the meeting. And now it's time to give the word to Professor Walter Canonica, co-president of the meeting. Walter, it's your time.
To say that it's really a pleasure. Why it's a pleasure to go ahead with lung health? Because we are a team, and I will be very pleased then to introduce all the other chairs of this meeting. But you know, team means also to have a good organizations, and for this reason, I wish to thank Public Creation, because as PCO, since the beginning, since 2013, they collaborate with us in creating first, and then in going ahead with this meeting. And I do hope really to have a face-to-face meeting next year, finally. Also because I miss the relationship, the human relationship that unfortunately COVID is really depriving us. And what about the topic? Francesco already introduced the topic, treatable traits. Treatable traits is, may I define it, is a little bit a tricky definition. Why? Because nowadays we are talking about personalized medicine, we are talking about precision medicine, we are talking about treatable traits. I think that the discussion we will have on different diseases will clarify if this is the correct way to go. I have to move my camera also because today in Milan is really a sunny day. So I have the light that was against me, but I mean, that's time. It's time to go ahead. And to do that, I'm pleased to introduce all the other co-chair. And the names are Stefano Aliberti, no. Stefano Centani, yes. Johan Christian Virchow, and Tobias Welte, in alphabetical order, of course. And it's my pleasure to give the word to Stefano Centani for going ahead with this introduction.
Okay, thank you, Walter. You was beautiful in the sun, so thank you very much. Thank you to Francesco. And just few words by me. The full scientific program has been ideated more than 1 year ago, so before the COVID pandemic, and will be focusing on this, as designed on the treatable traits, as Francesco and Walter said before. But the scientific committee decided, considering of course, the importance of the topic, to dedicate the last part of this workshop to make a point on the state of the art of knowledge on SARS-CoV-19, just 1 year after the Chinese official outbreak. So we can go on, and it is really a pleasure to give the microphone to my old friend, Professor Johan Christian Virchow. Christian.
Thank you very much, Stefano. From my side, welcome. First of all, Happy New Year, and I hope this new year will be better than the last one, although it is starting a bit bumpy, isn't it? The previous 7 meetings have indeed been wonderful, and I think I need to congratulate everybody for making this undoubtedly not as we had wished it to become, but make it virtually possible. And I'd like to welcome also everybody who is joining us online. We all agree, as Walter said, that we'd much rather meet in person, but unfortunately this is not possible as we're fighting second and third waves of this dreadful pandemic. Nevertheless, I think we're up to a good meeting. The program is very interesting. I think it is most appropriate to talk about treatable traits, because I think this is just another buzzword that we should put in the garbage bin as soon as possible. But nevertheless, I think it's important to talk about it. And this is very important to talk about when we talk about personalizing medicine, which becomes more and more a reality in pulmonary medicine, which I think is a wonderful development. Now,
Good afternoon to everyone. As suggested by Professor Aliberti, whenever you would like to start the discussion, you can. And if you need any kind of technical assistance, I'm here. I'm Teresa, and you can just ask me. Thank you.
Thank you.
Thank you.
Thank you.
We can't hear you.
Oh, sorry.
Okay.
Yeah. Is it better? So we were given an article to read. So I'm not sure how many of us were able to read it. I just managed to, leaf through the article. What about you, Olga?
As well. Just use through the article, but so maybe we should like start from the beginning and
Maybe someone can demonstrate, like share the screen, the article.
If you want, I can give you. I can give to one of you the power to share. So just tell me and.
So what I've done is I've made a PowerPoint presentation having the different points of strobe. So what I suggest is, if it is fine with others, what I suggest is that probably we can go through the the checklist of strobe, and so and side by side we can also refer to the article and look for the points there. Would that be better, or do we want the article on the screen? I mean, I can see my article on my iPad, so if
Okay, we also can see articles like here and
on the screen.
Yeah, and a screen can compare with strobe.
Okay, if you want, I can share the article for you, but then I don't know when to scroll. Otherwise, any of you can share the screen. So up to you. So, you are free to do. Okay.
So I'll share the screen if it is fine.
Yeah, would be nice.
Right. So is the screen visible? Right. Can we see the article?
Yes, but
can, right? Okay. Great. Okay. So I'll just open the strobe document. Just 1 second. Right. Okay. So, okay. So I think we have less than 40 minutes to go. Okay. So the first is, I mean, the first item number on strobe list is, I mean, please stop me if if I'm going too fast, or somebody thinks that I should be doing something else. So first item number 1 is title and abstract, right? So first it says that indicate the study's design with a commonly used term in the title or the abstract. Indicate the study's design. So in the title, we should be having the study's design.
Yes, for me, it doesn't indicate the study's design, the title.
Yeah, so it does not. So it does not talk about whether it's a prospective study, or does not talk about that, right? So what I will do is, you can see the screen as well, my PowerPoint.
Yeah, we can see.
Yeah. So I had mistakenly written as yes, but you're right. So there should be no, actually, because it does not mention the study design, right?
Yeah, it doesn't mention.
Right? Yeah. Okay. So that is one. Secondly is provide in the abstract an informative and balanced summary of what was done and what was found. Right. So this is the abstract. Okay. Okay. Right. So I don't know if you guys are reading it. So I read through it. It tells you about, what was the aim, right? And it was an international multi-center observational prospective study, right? There were 3 groups, and they, took on board 905 patients, and they described those patients and the results, right? So these findings, and they ultimately conclude that, how the results of the study, they are applicable. These findings on AMI versus other CVs as complication of CAP may be important when planning intervention studies. So for me, it was a balanced summary. What do you suggest?
Okay.
I would say it's also no.
Yeah. So the only thing which I felt was not there was that they did not mention the duration of the study there. So it was done over, I think, 2 years between 2000 and, so they have mentioned it in the results section, but it was not there in the summary. But still, I think it was otherwise a balanced summary. Is it not? Yeah, you would agree with that?
Yes, it's okay.
It's okay. So I would probably make this yes then. Right. Yes. Okay. So next is, so all of you have read through the article once, right?
Yeah.
Yeah. So it talks about the incidence of heart attack or acute myocardial infarction in patients with community-acquired pneumonia, and it tells us that certain factors, certain risk factors are associated with increased chance of heart attack or acute myocardial infection or other cardiovascular events, right? Okay, fine. So that's that. So next is the introduction, background, and rationale. So this is it. So this is the background. This is the introduction and the background. So what it mentions is that explain the scientific background and rationale for the investigation being reported. So they talk about the mortality of community-acquired pneumonia and what the current literature talks about, right? Yeah. And they talk about, what is the cause of genesis of myocardial infarction, plaque rupture, and how it happens. And finally, they talk about, so they actually build the background that why they are planning this study. So for me, it looked okay. What do you suggest? Sorry, so I'm sorry, I don't know, am I going too fast?
No,
it's okay.
Yes, I think we agree with you, because this introduction is quite wide and
right.
I don't know.
So this is the question as well. Explain the scientific background rationale. So
yes.
So we think it's fine, right? So
yeah, explain. We can.
We can. Fine, fine. Okay, so just a second. Yeah, this one. Okay, next they talk about state-specific objectives, including any pre-specified hypothesis. Okay, so this should come within the introduction. Did I do something? Sorry.
And the objective was the defining of prevalence, characteristics, risk factors, and impact on clinical outcomes. So it's okay, but there is not any hypothesis.
Yeah, there is no hypothesis, right?
No.
So somebody else is I think public relations, they are sharing the screen now. Okay, fine, that is fine. Okay, so okay, but the point is, if they are sharing the screen, then I cannot move to my, can I just 1 second? Yeah. So
yeah, you can share a screen.
Yeah, so this is fine. Right. So they have not talked about this, right? Specific objectives, including hypothesis, they have not talked about that. So what I've done here is I have, I have said that this is, so I would just say this is no, no, right? Rather than a query mark, I can just put it, this is as no, right? You agree?
I don't know. I agree or not, because I don't know how to evaluate it, because there is a state of specific objectives, but maybe it
okay, okay. So we designed a study with the objective to define the prevalence of, okay.
Yes.
So this last
Yes
line
or
they
not?
have,
Yes.
okay, risk factors impact. So this, so I mean, on second thought, this looks okay to me, right? Does it not? I mean, so in 2 lines they have mentioned about they want to see the prevalence, characteristic, risk factors, and impact on clinical outcomes of AMI. So this looks okay to me. What do you suggest?
As for me, it's specific objectives.
It is, yeah. Okay, okay, please. So I was wrong here. Actually, I was doing it very quickly, so I got this wrong. Sorry. Okay. So so next is they come to the method section, right? So they have said that in study design, present key elements of the study design early in the paper. So they have talked about, yeah, international multi-center observational prospective cohort study of consecutive patients hospitalized with the diagnosis of CAP in 8 acute care hospitals between October 2019. So over 3 years they did it to 2012, right? So so this is fine. I think this is fine.
This is fine. Yes.
This is fine. Okay. Okay. They also say they have also talked about describe the setting, location, relevant dates, including periods of recruitment, exposure, follow-up, and data collection. So I don't think they have done that. They have just mentioned that this was a study done between 2009 to 2012, but they have not exactly mentioned between what time did they recruit, what was the, I mean, exposure, I mean, for how long, so follow up, data collection. So do you think that they have been very elaborate on these measures? So I'll just show you this. Sorry. So what we want is the next next page, right? So what I'm talking about is describe the setting, locations, relevant dates, including periods of recruitment, exposure, follow-up, and collection, data collection.
There is not specified the time of recruitment and the time of the follow-up.
They have not. Yeah, that's what I. So I put a N here. So you would agree with that?
Yeah.
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 Okay. Dr. Animesh, sorry to interrupt, but they have mentioned that there is a supplementary material.
It could be, yeah.
Yeah, so they have mentioned there is
online supplementary.
Okay. Okay, but I'm sorry, I could not go through the online supplementary material.
Yes,
So-
but did anybody find this online supplementary material?
I think we were to. So was this Dr. Arun said this?
Yes.
Achha, Dr. Arun, may I request you if you can fish this out from the internet? Is it possible for you?
Yeah, just let me try.
Okay, please look into this. Fine. So this is clearly not it. Just 1 second. Yeah. So the next question is, give the eligibility criteria, sources and methods of selection of participants. Describe methods of follow-up. Okay. So I think so they have mentioned on the inclusion criteria. Patient more than 18 years of age, satisfying criteria for CAP. Patients with hospital-acquired pneumonia, defined as pneumonia, they were not included, right? So patients with the diagnosis of healthcare associated pneumonia were included. So they have mentioned
inclusion criteria.
Yeah, inclusion criteria. Sources and methods of selection. Sources. So they are talked about the hospitals previously, multi-center, Italy, and 8 hospitals there, and they have talked about consecutive patients. So they have described methods of follow-up. They also talked about follow-ups.
Yes, it do.
Right. So
Yes,
I
it's
think,
okay.
Yes, it do.
So it looks okay, right?
Yeah, it looks quite good.
Quite good, right? So so 6A where I put Y. For match studies, giving matching criteria. So this was not a matching. So they have not matched, the participants with others. So I just written NA means not applicable. Would you agree with that?
Yeah. It's not a match study.
They were not matched. I mean, they are not taken, say, another infection and, try to see the AMI in those population versus vis-a-vis, I mean, community acquired pneumonia. So I think this is not applicable. Is it fine?
Yes, fine.
Okay. Okay, next you have talked about clearly define all outcomes, exposures, predictors, potential confounders, and effect modifiers. Give diagnostic criteria if applicable. So yeah. Okay, so all outcomes. So they have defined, here AMI, acute cardiogenic pulmonary edema. They have defined AMI. Criteria for AMI were defined as detection of rise and a fall of troponin with at least one value above 99 percentile. And they have, talked about the diagnostic methods of AMI, and they have said for the others, you refer to the online supplementary material. So probably we have to also, pull it up for looking. But probably they must have mentioned it. So this looks probably, they have defined outcome, exposure. So have they defined, so exposure here would be, I think, people who have community acquired pneumonia. So I think they have also defined, so have they talked about how they have made a diagnosis of community acquired pneumonia? Because I don't think they have, unless they have mentioned in the online supplementary material. I mean, anybody with an X-ray shadow may not be community acquired pneumonia. So I'm not sure. So again, we just need to probably check the online supplementary material for this.
Yeah,
Would
they
you
just
agree?
mentioned supplementary material.
Okay. Okay, fine. So here I think I've just put for so exposure. Okay, exposure predictors, potential confounders. So have they defined predictors over here? I don't think they have defined, but what would they define? So predictors, they have mentioned, liver disease, female gender, sepsis. So have they defined that? So, if you would read into the, into the article, they have later on mentioned that which patients had higher risk factors for developing myocardial infarction or other cardiovascular events. And they have said that, there are some risk factors like female gender, which is which we can understand. They've also said about sepsis, severe sepsis, liver disease, but have they defined it? I mean, I'm not sure about that. Just once, and I think so. They've talked about study outcomes. They have defined time to clinical study, length of hospital stay in hospital. Okay, clinical failure, but could anybody find how? So I mean, what I'm trying to say is, did I? So suppose in the abstract, now if you would see this one, female, sex, liver disease, and presence of severe sepsis were independent predictors for the occurrence of AMI, right? So this is understood, female gender, but how have they defined liver disease? I mean, liver disease, anybody with, I don't know, with some liver enzyme increase may not be liver disease. So they have to actually define it. So have they defined it? I'm not sure about that. Is my question making sense?
Yeah.
Actually,
Yes,
it makes sense.
Yeah, so they should be categorical. So categorically, they should specify that this is how they have defined liver disease. So I don't know, probably we need to, so I think I'll just look this up once. Yeah, so here I have put, yeah, so here I put query here because I was not sure whether regarding predictors, they have talked about that. They've also talked about potential confounders. So in our
Potential
study,
confounders.
so in our study, I think there were no potential confounders. So I don't know. So they have not talked about confounders and effect modifiers. So that's the reason why I put query mark over here. Would you agree with that?
I think it's very important aspect to consider potential confounders and effect modifiers in a cohort study, and they didn't analyze it here.
Right. Okay. So so I think would you be happy with the question mark here, Antonia? You want to know? I mean, Y is not there. You want to, so I think N should be there. We should say it's an N. N means no. Are you happy with that?
Sorry?
Are you happy with a no, or you want it to be a question mark? I'm just worried with the number of N's because if I hope Dr. Stefano does not.
They defined the outcomes very well, very detailed, but they didn't.
They did not address this. So we'll just put it as a no and we'll just see.
Yeah.
Okay. So regarding the next thing is data sources measurement. For each variable of interest, give sources of data and details of methods of assessment. Okay. Details and methods of assessment, measurement. So suppose they have done myocardial infarction. So, they have measured troponin. So have they talked about how they have measured troponin? We'll have to see that. I mean, which study kit was used. And so I'll just see. So I don't think they've just mentioned word fall in troponin with at least one value over the 99 percentile. So
That's criteria.
Yeah. But I don't think they have mentioned this. For each variable of interest, give source of data and details of methods of assessment. Or have they talked about, so variable of interest. So what do they mean by that? So variable of interest. So do they mean the outcome? I mean, mortality is okay, but somebody is dying, that is fine. Have they talked about, length of stay? That is also very intuitive. I mean, how many days the people are staying, right, in the hospital. So outcomes, I'll just see time to clinical stability and length of hospital stay and in hospital mortality. So they have mentioned that. So I think they mean this. I think they mean this variable interest. So I was not sure about this. Any suggestions from the house? I mean, what should we do regarding this?
I think they give the details of methods for assessing the study outcomes, which are the variable of interest. I think they did it well.
They did well. Okay. So variables of interest would be these, and you're saying they have defined that. So this should be all right, right? It should be all right then. It should be yes then.
Of interest, is it actually the risk factor, the predictors, or the outcomes?
I think both, which varies in the study. So even the gender, etc., varies as well as the length. So anything which is varying in the study. So it should be, I think, all. I mean, both the outcomes. So I think. So I think we can just put a we'll put a yes over here, and then we'll probably.
Yeah, we will just say yes for the outcomes variables, but for the risk factor variables, they didn't.
We are not sure about that. Okay. So yes, and then a question mark. Okay, fine. Bias. Describe any efforts to address potential source of bias. I could not find in the study whether they have discussed bias or
I
not.
also haven't found it's not exist here.
So what I did was I just one second. I just okay. I'm sorry. So I just fact, I think there is no, I searched bias. There is no
Maybe
word. It's not there.
Maybe in online supplementary material as well.
Okay.
Clinical failure also there. It could
Right.
be.
It could be. It could be. So we need to. So I think we need to then look it up then once. Okay. So next is.
It's not very
Okay.
comfortable to look for all this supplementary material.
Online supplementary material.
It's not okay.
Yeah. So I think probably Dr. Arun might be helping us with that, or probably we can just finish this and then take a look at this online supplementary material. Is it fine?
Yeah, it would be nice.
It would be nice. Thank you. So next is study. Explain how the study size was arrived at. So I could not find that.
It's
They did not tell us.
Yes, it's it doesn't exist here.
So it does not exist in the study. So I've just mentioned no. They have also talked about explain how quantitative variables were handled in the analysis, if applicable. Describe which groupings were chosen and why. So as far as so continuous variables, like in this case would be the length of stay, right? So regarding the outcomes, I'll just go through the outcomes once. So time to clinical stability and length of hospital stay, so they would be two continuous outcomes, right? As opposed to mortality, where it would be yes or no, so it would be a qualitative outcome. So I don't think they have how quantitative was. And so just one second, I'll just move on to the statistical analysis. Yeah, all data was statistically analyzed using SPSS. Descriptive statistics were reported at baseline with continuous data expressed in mean plus minus SD. Okay.
They describe the quantitative analysis.
Yeah, so that is then that should be fine, right? Yeah, so it should be fine then. Okay. So I'll just put a query. So I'll just put probably a yes over here, right? Okay. So describe all statistical methods, including those used to control for confounding. There is no, I could not find any confounding, so that's the reason I put no here. Would you agree?
Yes.
Yeah.
Okay. Describe any methods used to examine subgroups or interactions. I could not find anything about subgroups or interactions. Have they looked at independent? They have talked about independent predictors, but I don't think they have done a regression analysis, or they have talked about sensitivity analysis or subgroup analysis.
It's not applicable for this.
Logistic regression was used in this analysis.
Was it?
Yes,
Regression was used?
Potential predictors of the occurrence of CVE and mortality were investigated with a multivariable binomial logistic regression analysis.
Okay. So you're
sentence.
Oh, so the last sentence, right? On logistic regression analysis, after adjustment for severity of the disease, immunocompromisation and risk factors for multi-drug resistant pathogens, the presence of EMI. Okay. So they have done something about that, right? So I think then we should then change this to which one?
Yeah, it can be yes.
Yeah. So describe. So this should be a yes. This should be a which one should be the B should be a yes.
Yeah, you can put that.
Yes. So they have talked about right. This should be yes. Explain how missing data were addressed. They have not talked about missing data, have they?
And I haven't read.
Okay. I'll just search missing here. I'm sorry, I could not read word by word. I don't think they've missing or lost to follow up. Loss of viable myocardium. No, so I don't think they've talked about loss to follow up as well. So and so they have not. So just 1 second.
No, I don't think they put about how to handle missing data here. The method.
So normally what in our hospital, what usually happens is some people have community acquired pneumonia, suppose they're admitted, right? And somebody wants to leave against medical advice. So we don't know the future course of those patients. And they suppose they have a myocardial infarction or don't have a myocardial infarction after they are they have gone from the hospital. In those cases, I think those people cannot be followed up, but you have already recruited them. Then those cases would be lost to follow up. Would you agree with that, Antonia?
Yeah, I agree. It's true.
But here they have talked about they have recruited 905 patients, but what happened to those patients who were, I don't know, is there any loss to follow up in European hospitals? I'm not sure. I mean, do any people take discharge against medical advice? Does it happen? So, you know.
So I think it can happen even in Europe.
That's right. Okay. So, but they have not talked about loss to follow up. Or suppose a patient comes and, you know, dies within 1 hour. So we are not sure why the patient died, right? It may be due to heart attack. It may be due to, I don't know, severe sepsis. So if you're not doing an autopsy study, we don't know. So in those cases, how do we infer whether the patient had a heart attack or did not have a heart attack? Does it make sense? So I don't think so. I think there is a ground for mentioning loss to follow up here, but I think they have not mentioned it.
Yeah,
What do you
also
say?
I thought they didn't mention whether there is any patients lost to follow up or not.
They have not, right?
No, no.
Not.
Okay, they have not. So, so we'll just. I mean, if you're wrong on some count, I think Stefano would not mind too much. So
Put it now first. If we find new information, we'll change it.
we'll change it. Yeah, that makes perfect sense. Right. Explain how to, if applicable, explain how loss to follow was addressed. I put a no here because the first C was no. Describe any sensitivity analysis. So I don't think they have mentioned anything. So they have done a logistic regression, but I don't think they have done any. Have they done a sensitivity analysis anywhere?
How does it look like, the sensitivity analysis?
How does it look like?
Usually, people do sensitivity analysis. And Nimesh, have you ever done it?
Yeah. So sensitivity analysis normally what happens is, so you know. So in this case, so suppose people are having community acquired pneumonia. Suppose if they already have comorbidities, right? Suppose somebody is old age, have comorbidities, and you know heart disease, previous heart disease. They have a myocardial. They are admitted with infection, so they probably would have higher chance of having a heart attack or a myocardial infarction, right? So in that case, suppose if a study has among 905 patients, they have say 900 patients who have these comorbidities. These, I mean, they are advanced stage, they have heart disease. So then, you know, they should then the final result of the study would not be it cannot be generalized. So in that case, they have to do a sensitivity analysis, taking into consideration that, you know, higher number of patients in the group already had risk factors for AMI. So, you know, this is so what they need to do in that case is, suppose 500 patients had those risk factors, they need to see not only in the whole group, they need to also see in that 400 patients separately. So they are making subgroups, patient with significant comorbidities, patient without significant comorbidities, and they need to see whether, you know, the chance of AMI is more or less same or not. So basically they balance, they make calculations by which they are balancing the different comorbidities. So something like that. So but
Do it here.
is it here? No.
Yeah.
But, so they have done a adjusted odds ratio. Right? Sorry, who said it's there? I mean,
No. I said that Arun posted online supplementary material.
Oh, he did?
Yeah, in chat.
Okay. So what should we do? Should we just finish it quickly? I think we have one more slide left and then go into that online. Is it better? Okay. Right. So just sensitivity, I think I've just put it as a, okay. Described missing data. I just put a query mark here, right? So we'll just take it from here. Just 1 second. I think we have 2 more slides. Okay, so these are the results. Report number of individuals of each stage of study. Example, numbers potentially eligible, examined for eligibility, confirmed eligible, included in the study, completing follow-up and analyzed. So since they have not reported loss to follow-up, so I have put a no over here. Would you agree with that? I mean, they have also not mentioned that, you know, they have also not mentioned, they have also not, they have also not mentioned, you know, how many were examined for eligibility, confirmed eligible. So they have not mentioned that. So I thought I would put a no to that. Would you agree?
Agree.
Okay. Okay. Give reasons for participation at each stage, non-participation at each stage. So again, I could not, so we don't know how many people were not there. So no reasons were also given. Consider use of a flow diagram. I could not see it. I could not see it. So this is all no. Give characteristics of study participants. This they have done. Demographic, clinical, social, they have not done, I think. But rest they have done. They have mentioned how many people had diabetes, what is the age, etc. Right? So this is fine. Indicate number of participants with missing data for each variable of interest. So again, if they don't have the, they did not tell us how many were there at the end of the study, I think, so I've just put a no over here. Fine. I hope, I think I'm going a little too fast.
No, it's okay.
It's okay. Summarize follow-up time. Example, average and total amount. So
30 days.
30 days, right?
Yes, all the follow-up time was 30
So
days.
where are you seeing it? Which page? Page number?
At the beginning, in the methods.
Results.
Earlier? Yes.
Earlier?
In
Yeah.
methods. Here, the third from the beginning. Yes, 30 days mortality. No, 30 days mortality.
Mortality, right.
Not follow-up, yes.
Okay, follow-up. So we just need how many, so I think it would be in the result, then how many patient characteristic, risk factors. So we need some summarize follow-up time. Just
We can hear you.
We can't hear you, Animesh. Microphone.
Yeah, so just give me 30 seconds. Somebody's at the door and my son won't be able to open the door. Just 30 seconds. Ищи.
Если честно, я плохо понимаю английский.
The supplementary material is
Через слово.
Did any of you go through the supplementary material?
We can.
Supplementary materials.
I have found the follow-up 30 days in materials and methods. The second abstract, telephone call or visit to the clinic was performed by one of the investigators in each study center 30 days after the diagnosis, and that's all. So after the 30 days, they called them, and this follow-up was finished.
So where exactly are you reading?
Material and methods.
Yeah. So can you see my screen?
Yeah. Yes, I see the second abstract. The second and
second paragraph. Second paragraph.
The second paragraph, yes.
Which sent 30 days after diagnosis was made in order to. Okay. Okay. So here they have said that summarize follow-up time. Nee, but what they need to mention is here they have, they have called every patient after discharge at the 30-day mark. But this is what their material and methods is. But this we are seeing the results, right?
Yes.
In the results, they have to talk about the follow-up time. I mean, how many people have been followed up, for how long, average was this, median was this,
Yes, you're
right?
correct.
So I don't think they have done that. Results. So impact on clinical outcomes. Length of hospital stay was 10 days. But they would say that, okay, but they would say that we have followed up the patients for 30 days. I mean, we have telephoned them after 30 days. Summarize follow-up time. Summarize follow-up time, average and total amount. So probably they have followed up every patient till 30 days. So what do you suggest? I think, so in the results, clearly they have not mentioned about anything about the follow-up duration. They have just mentioned about length of stay in the hospital, but it's clearly not the follow-up time, right? I mean, some people might have died at, say, the 10-day mark. Some people might have being discharged, say, on day 20. But so for how many? So to me, I don't think that they have mentioned the average follow-up time. What do you suggest?
You're correct. Yes.
Okay, so probably we'll just put it as yeah. So follow. So here you can receive outcome results. Yeah. So follow-up time. I put it as no. So we'll just keep it as this, and probably we'll change it if required later. Report number of outcome events or summary measures over time. So this they have mentioned, how many people had a myocardial infarction and other things. That is fine.
Yeah.
Give unadjusted estimates, if applicable, confounder adjusted estimates and their precision. Make clear which confounders were adjusted for and why they were included. Report category boundaries. So this they have definitely, I think, done. Category boundaries they have mentioned about length of stay, and they have mentioned the interquartile range. So, for example, they have mentioned the median IQR time, clinical stability, right? Length of hospital stay. They have done that. So, second point they have definitely done. First is unadjusted estimates and confounder adjusted estimates and the precision. The precision. So how do we address this? So give unadjusted estimates, confound adjusted estimates, and the precision. Declare which one. So I don't think. So they have done a univariate analysis. So by that they can take out some confounders, univariate and multivariate and logistic regression analysis. But so normally what happens is, I'm just taking you to, normally what happens is that 21 patients, 2.3% patients experience at least one AMI, right? So they are supposed to mention a 95% confidence interval, because taking into consideration the sample of the study. So if the sample of the study is lower, then the confidence interval would be larger. Does it make sense? Okay, so what I mean to say is,
but I see that this sample is very low. 21 patients is not a good amount for analysis.
It's a good amount? That's what you're saying?
It's not a good amount.
It's not a good amount, right?
Yeah.
So what I'm saying is, suppose they did it on 90,000 patients, right? Then also, we could have a different result. If they did it on, say, 90 patients, they would have a different result. So for everything, they are supposed to mention a confidence interval. I'll just show you another paper perhaps where, beside every percentage, they mention a you know, depending on the sample size, they
Yes.
mention a confidence interval. So I think they have not done that for that, right? So so that's the reason why I have just put it as I think I put it as y. So I think I'll put it as question mark if you agree.
Yeah, I'm agree.
Yeah. Report category boundaries when, so this we have talked about. If relevant, consider translating estimates of relative risk into absolute risk for a meaningful time period. So they have talked about odds ratio. They have talked about, I'm sorry, here, they have talked about adjusted odds ratio. So they talked about AOR, adjusted odds ratio. So that's a kind of relative risk. But I don't think they have talked about absolute risk.
Mhm.
Hmm? Yeah, there's a, I mean, the term relative risk and absolute risk, does it make sense? I mean, so right. So I think though they have not talked about that directly. So I think that's the reason why I just put question mark over here. Right. So I think we'll just discuss it with Dr. Alibati also once, right? And finally, in the discussion, they have talked about key results that they have done, limitations, describe the limitation of the study, taking into consideration sources of potential bias or imprecision, discuss both direction and magnitude of any potential bias. So I don't think they have. So if you would see the limitations.
I saw the limitations of
Yeah.
the study.
Limitations.
Yes.
Yeah. Yeah. This one. A study has some limitation. It designs, its design suffers. Its design suffers of the missing of the complete evaluation of other risk factors, right? Long-term outcomes at 1 year follow-up. Coronary angiography was not done. So other tests were not done. But so are you happy with this? So so suppose for me, the other limitation is that it was a single continent study. Is it a limitation? I mean, does not talk about Asian patients. It does not. It's not applicable to me.
Yes, yes, I think also it's a limitation. Yes.
So so I was not happy with the limitation. I was not, I mean, too happy with the limitations, I would say, because
But a little happy, yes.
a little happy, yeah. Yeah, right. So interpretation limitations, give a cautious overall interpretation of results considering objectives, limitations, multiplicity of analysis, results from similar studies. So this they have done. They have, I mean, their discussion was, you know, they talked about some limitations and they have talked about the objectives and what are the implications that they have done. Discuss the generalizability of the study results. So again, I did not find, you know, we have not talked about that.
This, yes.
Yeah, yeah. So the question mark. And finally, they have not talked about funding. Could you find anything about funding? I could not find anything about funding. So, you know, but this study is unlikely to be, you know.
Free study.
Sorry. Very inspiring. Study, you mean?
No, I so
It
doesn't matter.
Okay.
So I also didn't find.
They have filed separate disclosures.
Yeah, have they? Acha. Yeah. So where have they done it?
Yes, disclosures.
There are 4 others who mentioned their disclosures, fundings.
Acha, where? Acha, they have done it at the start. Where have they done it?
Supplementary material to that as well.
Okay. So can is it possible for you to share the
I
supplementary
shared the
material?
link. Just go through there.
You've shared a link. Okay.
Just
1 second.
If you're on Mac, you can directly download it. I already posted the file.
You have shared it, you said?
In the chat box.
Yes, there is a link.
Just 1 second. So how do you go to the chat box from here? resume share. So should I stop share? And
actually, there is the definition of severe sepsis, respiratory failure.
Okay, I'll just stop share and okay. Okay, so this is the supplementary. So I'll just 1 second. So we are able to see this.
Yes. Yeah.
Yeah. Okay. So Dr. Arun Singh, there are disclosures. So I'll just see this disclosures.
Disclosures are mentioned separately.
Okay. Can you just guide me where it is? Front, back?
Okay, I'll just a second. I am posting another link.
Okay. So I'll just go through this data collection, charts of all patients are abstracted, standardized forms, study definitions. Okay, so they've done that. They've defined community-acquired pneumonia, severe sepsis, they're defined, respiratory failure, sepsis, shock, clinical failure, they're defined. They have defined all of them. So I was wrong on there. Okay, they've also defined liver disease. Okay.
Yeah, liver disease.
Okay, right. So they've done that. They've also talked about microbiological examination, what they have done, how they have diagnosed the causative organism. They've also talked about AMI and the other definitions: pulmonary edema, new arrhythmia, cerebrovascular accident, pulmonary embolism. Okay. And they have talked about references. Okay, they have talked about references. There are tables here, recent demographics. Okay. They have talked about comorbidities. I think comorbidities. Okay. 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 So they've done that. They have done clinical lab data. They have done this. Platelets. Different things they have done. And they've done a microbiology and empirical antibodies. So the treatment received, they have done that. For treatments. Okay. We have talked about the odds ratio here. Univariate analysis they have talked about. And they have talked about. Okay. They talked about the baseline demographics. Okay. And radiology they've talked about. Figures. So they've just defined the figures over here. Participating centers, appendix they've talked about. Achha, I could not find any funding. Sorry.
There is
There's another appendix.
I posted a link in the chat box. Just go through the link. There are disclosures from different authors.
This one. Okay. Next one you have said. 735. But disclosures are fine, but who funded the study? I'm just saying.
All the others mention their own affiliations and funding.
No. So are you talking about this one?
Yes, you go through the link, you just get all the data. So you have disclosures from Dr. Alberti, Dr. Blassi, Dr. Stolz, and Dr. Valenti.
That is fine. I mean, what I'm saying is, suppose somebody is disclosing that they have received, grants and I don't know, hospitality services. That is fine. But what I'm saying is, who funded the study? That is separate from disclosure. Disclosure is like, this pharma company has funded my, I don't know, foreign visit for a fellowship or something. But funded is who gave money for this. Was it given by a particular pharma? Was it given by an institute, their institute? Was it given by WHO? So that is important.
That's not mentioned.
These are mentioned.
It's not mentioned. It's not mentioned.
It's not mentioned. So that's what I was saying. So, but that is important. Would you agree with that, Dr. Arun? Is it important?
Yes.
Yeah. Okay. Fine. So okay. So we'll just go through this once. So if I am presenting, if I get stuck, I would count on help from you guys, right? That otherwise, Dr. Aliberti might have a field day,
Yes, Professor Aliberti is arriving in 5 or 10 minutes. He apologized with you, but he has just a short delay.
Okay, no issues. Thank you. So just go through this once. So 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 we just tell me if we need to modify anything. Is it okay if we do that? Do that once?
Yes.
Yeah. Yeah. So title and abstract, we said indicate the studies designed with a commonly used term. So we thought it was no, because they have not talked about the studies design. That is fine.
Yes.
Right. Okay. So they have provided the abstract and informative and balanced summary about what was done and what was found. We thought that it was okay. Sorry. Fine. Explain the scientific background and rationale for the investigation we reported. We thought that it was a yes. State specific objectives, including any pre-specified hypothesis. So objective was not mentioned in their introduction, or was it? I think they did it, right? I mean, so in the introduction, they mentioned we designed a study with the objective of defining the prevalence, characteristic, risk factors, and impact on clinical outcomes. So is it fine? Should this be a yes then? Right, this should be a yes. I don't know how. So did I not save it? Okay. Okay. So so present key elements of the study design early in the paper. This was a definite yes from all of us.
Yes.
Yeah. Okay. Describe the settings, locations, and relevant dates, including periods of recruitment. This we felt it was not done. Even in the supplementary, we saw it was not done. Give the eligibility criteria and sources and methods of selection of participants. Describe methods of follow-up. So this was done. This was done, right? This was done.
Yeah, okay.
Yeah, okay. For match studies, we felt this was not applicable. Clearly define all outcomes, exposures, predictors, potential confounders. This they have not done, right? No, it's a no, right? For each variable of interest, give sources of data and details of methods of assessment. Okay, can I describe? There is more than one group. Give source of data and details of methods of assessment. So should it be a yes? Variable of interest. We thought that length of stay they have defined, clinical stability they have defined, but liver disease, etc. They have also defined that. So this should be a yes. Is it?
We found then in supplement liver diseases.
Yeah. So just 1 second. I'll just So I should just make it yes. Dr. Arun, you agree with this?
Yes.
Yeah, please. Right. So we are here. Bias. Describe any effort to address potential source of bias. We could not find any, bias. But the question is, what kind of bias could be here? They've just followed. They've followed patients with community-acquired pneumonia. Bias is anything which deviates us from the true result of the study. So have they done? What can be a potential source of bias here? Can there be a potential source of bias here?
Hello, everyone. Hi.
Hello.
It's a good time.
Yeah, sure.
Did you enjoy the past hour?
Yeah.
Good. Can we work together, or you need more time?
No, it's fine. I think
You may start. Yeah.
Ah, very good. Very good. So who's gonna speak?
Animesh.
Yeah.
Very
We
good.
were just discussing, you know, I mean, our critique of the study, right? So we agreed on most points, but you know, regarding some points, we thought that we would need more time, or we would need your inputs as well. So right. So this was the you know, the study which we were told to critique, right? So what we did was we just made a list of the you know, the different points in the Strobe statement, and then we have put a response also beside this. So it's a N means no, Y means yes, and we also have a NA means not applicable, and we have also a question mark means you know, we are divided, or we are not sure about that.
Okay.
Right. So first is title and abstract. Indicate the study's design with a commonly used term in the title or the abstract. Now we felt that the study's design was not mentioned in the title. So it was acute MI versus other cardiovascular events in community acquired pneumonia. So we felt that it was a definite no.
Yes, this is very important, Animesh. I mean, it's not mandatory. It's not mandatory, but highly impact factor journal, especially if you're publishing randomized control trials, they want you to put this clear in the title. And the reason why is because is useful for the literacy research. So you can quickly understand the study design. So if you're searching, for example, for randomized control trial, you don't need to go through that study. So this is very important. On the other end, let me tell you something about the title, because the title is a sort of not credit card, how you say in English, is a sort of presentation card of your article. So choosing the right words in the right way with the right keywords is very, very important. So first, some journals do not allow you to put more than a specific number of words or even characters. So this is really tricky, because you need to combine, you need to have very much clear in your mind the message you want to deliver, and that message should be in the title in a more concise way. Second, if it's a randomized control trial, my personal suggestion would be to put this in the title. If this is a systematic review and meta-analysis, my personal suggestion would be to put this in the title. According to the Strobe, Consort, Prisma guidelines, and blah, blah, blah. The third point is about the relationship between title and keynotes. So what you want is your article to be found and to be cited. And usually people are doing this through putting on PubMed words. So you need to have keywords, usually from 3 to 5 keywords reported in the manuscript, and then your title. I would suggest not to overlap words between keywords and title, because this is useless. So if you put pneumonia in the title, do not put pneumonia as a keyword, because it is already in the title, and vice versa. So when you are choosing the title, and I think that this is the last thing to do before submitting the manuscript, you need to think about the message, the so what, the message you want to deliver. For example, procalcitonin is not associated with mortality in pneumonia, could be a good title, because the message is there, and the study design,
Yeah, yeah. Thank you for that. Okay. So next is providing the abstract and informative and balanced summary of what was done and what was found. So we all agreed that that was the case here. Okay.
However,
next. Yeah, sorry.
No, you go. You go.
Okay. Next was in the introduction, explain the scientific background and rationale for the investigation being reported. This was again a yes. And objectives, state specific objectives, including any pre-specified hypothesis. Initially, we could not locate it. Then we found it in the last paragraph of the introduction, where this was mentioned. So we felt that this was a yes as well.
So let me tell you this. You guys are definitely right. There are two major issues with this introduction. Well, one issue is that I don't like to put a lot of references in the introduction. I like more to cite references and papers in the discussion through a speculation, comparison between my findings and the other findings. So this kind of stuff. So this is the reason why you are seeing only 3 references here. So maybe someone could argue that the topic is not very well addressed in the introduction. And this is the first critique. And the second critique, which is the most important one to me, is the absence of a clear hypothesis. So we are generating the problem around the acute myocardial infarction in patients with pneumonia and the presence of other cardiovascular events such as arrhythmias. And we are saying that an head-to-head comparison between MI and other cardiovascular events has not been previously conducted. But we are missing the hypothesis. The hypothesis should be around a specific endpoint, for example, prevalence or impact on mortality or clinical characteristics. So the hypothesis would have been, for example, we hypothesized that that cardiovascular events other than myocardial infarction are more prevalent than acute myocardial infarction in patients with pneumonia. This could be the hypothesis. Or for example, the hypothesis, an hypothesis like we hypothesized that patients with acute myocardial infarction die more than patients with other cardiovascular events during a pneumonia. So the hypothesis is missing. And then when you the hypothesis, the hypothesis is the central message of the paper. For example, if my hypothesis is around the prevalence, and I would say that MI is more prevalent than the other cardiovascular events, then the objective would be to evaluate the prevalence, of MI in patients with pneumonia and its impacts on clinical characteristic and outcomes, blah, 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 blah. So these would be the secondary endpoints, right? So already in the objective of the paper, I identified the primary endpoint and the secondary endpoint. So this is the heart of my study. And then I build up a sort of several other things around the heart of my study. And then the title would be acute myocardial infarction is 3-fold more prevalent than cardiovascular events in pneumonia, for example, So hypothesis, objective, primary endpoint, first paragraph of the discussion, and title are all linked together.
Okay. I just wanted to ask you that, the hypothesis, again, is it a requirement that, it be stated upfront? Because in a study like this, it would not, what could the hypothesis have been in this case? Could it have been could it have been that because we are talking about prevalence, so we cannot say that we expect the prevalence to be so much, because we have already talked about this, that older studies talk about a certain prevalence and we are looking for the prevalence. So in our case, do you think that an extra line or an extra paragraph should have been added regarding hypothesis?
So it depends on what you want to show to your community. Of course, if there's no data on prevalence, okay, prevalence should be the first hypothesis, more than mortality, more than impact on mortality. So I want to know first the prevalence and then the impact on mortality, for example. Then if I already know the prevalence and the clinical characteristics, the second step would be to look at impact on clinical outcomes, for example. So it depends on you, but you're right, Animesh, it's not mandatory to put the hypothesis in the introduction, but is highly, 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 highly recommended. And the reason why is because I am a reviewer and I see hypothesis, objective, primary endpoint, major findings, I already decide if this is a good paper or is not a good paper. If I need to understand the primary, the hypothesis, the objective, what is the primary endpoint, the secondary endpoint, blah, 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 I get crazy and I trash the manuscript.
So, I mean, just the last question regarding this. So the reason why you did not mention a hypothesis in this particular paper?
No, the reason why I didn't mention hypothesis is because now I understand and I know this, and I didn't understand and I didn't know this at the time I published the paper.
Okay. So one more thing is what I felt, that the abstract did not mention the duration of the study. Do you think this is important?
Yes, I think it's important because this is the follow-up, and this is a observational prospective cohort study. So it's very important to understand if I spent 1 month, 6 months, 1 year, or 10 years in looking for cardiovascular events. So duration should have been there. Because of the length of the abstract allowed by the journal, I decided to put much more content in the results rather than in the methodology. So this was my choice, because if you look at on PubMed and you find an abstract with more than 50% of results, I think you are more interested than in going to the methodology. But this was my decision, but it's questionable.
Right. So next is, sorry, this one.
So let me stop you for a minute, Animesh. The other guys, the other colleagues have some question about the introduction, the generation of the problem, the objective.
Just discuss it a bit and maybe we agree.
We discussed
with
it all
Animesh.
together with Animesh earlier. So
We discussed before.
So do you agree?
Yeah, we discussed and agreed.
Very good. We move to methods, Animesh.
Oh, I have a question about what you said. Just want to confirm. So you said if the term is already written in the keywords, you do not need to use again the words in the title. Was like that?
Yes. Once you have decided the most important title, and you choose your title, and the next step would be to select the keywords. My suggestion would be not to select keywords you already put in the title, but choose other keywords that can allow more possibility, more chances that someone could find your paper during a literature research.
Thank you.
Okay.
Yeah. So next we moved on to the method section. So regarding study design, we thought that it was clearly mentioned that it's a multicentric study, prospective, observational. So we felt that it was a yes. Regarding settings, locations, relevant dates, including periods of recruitment, exposure, follow-up, and data collection. So we felt that though it was mentioned that it was done over, I think, 3 years. It was a 3-year study, but the exact breakup was not mentioned. That how many, when was the last patient recruited, and when was the last patient they completed their follow-up. We thought that this part was probably not there.
So Animesh, you're right. This is important. Let me remind you the importance of study setting and study period. Study setting and study. So first of all, go back one step back. The study design should be always there and clear. So not just we did a trial on, or we did a study on, or we did an observational study. No, I want to know the kind of studies, the kind of observational study, if prospective, if multi-center, if one site, the randomized control trial, I want to know if it's blinded, open, blah, 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 blah. So the study design should be detailed as much as possible. Study setting is very important because although you might find incredible results, but you enroll your patient in 1970 and we are in 2021, I need to interpret your results because in 1970, there were different standard operating procedures. There were different guidelines. There was a different way to treat patients than in 2021. So your results should be tricky because of that. So the period is very important. This is the case, for example, when the guidelines are published. Okay. The second point is the study setting. Also, the study setting is important because Italian patients and Switzerland patients might have genetic characteristics that are different from Ukraine patients. Maybe not in pneumonia, but think about alpha-1 antitrypsin deficiency. Maybe we have a more prevalent of alpha-1 antitrypsin deficiency than Black people in Africa, for example, or Japanese people. So it's very important to understand where the study setting was conducted, not only because of the standard operating procedures of the specific healthcare systems, but also for genetic way. Healthcare system is very important. For example, when we have an endpoint like duration, length of hospitalization. When we have length of hospitalization as an endpoint, either primary or secondary, having a patient hospitalized in the United States is very different than having the patient hospitalized in Milan, because the healthcare system is different. Okay, so the important reason why study period and study setting should be always there. I put these in the online supplemental material. You can do that. So another issue would be to decide together which kind of information should be put in the hard copy of the manuscript and which kind of information should be put in the online supplement. So you need to discuss this with your co-author. But in the online supplement, you can put whatever you want. So be detailed, be precise, be inclusive. Okay. Sorry, Animesh. There are some journals that want you to put the study protocols as an online supplement. Okay. The entire study protocol. Okay. So this is important.
So fine. So next is regarding participants, eligibility criteria, sources and methods of selection of participants, describe methods of follow-up. So we felt that inclusion criteria was mentioned. Sources, we are, they are talked about the different centers in Italy and Switzerland, and methods of selection, they had mentioned consecutive patients. So we felt that, and describe methods of follow-up. They have also talked about how they have followed up the patients. There was also a telephonic follow-up till the 30-day mark. So we thought that this was a yes.
Very, Animesh, you see that if you take a look at the online supplement, you will see that there are 8 acute care hospitals, 7 in Italy and 1 in Switzerland. I would be very keen to understand why 1 in Switzerland. For example, if I would have said there's 7 in Italy and 1 in Mumbai, why? Is this correct from a methodological point of view? You are putting in the same basket patients that are coming from a different centers, very far from themselves. So, or you are doing a very well-designed multi-center international study. But if you are doing 7 centers in Italy and 1 in Mumbai, there's something strange, right? I need to, what I want to do is to compare your results of the 7 Italian center versus the 1 in Mumbai to see if there are differences between those in Italy and those in India, you know? So the study setting is important from also from this point of view.
Okay, so if I understood you correctly, you're saying that probably not all multicentric studies should be, I mean, viewed in the same light. I mean, so suppose Italy and Switzerland, I think they're not contiguous. So we should also think about why this is so, because I think the most probable reason would be there's a collaborator in Switzerland who is ready to work. Is that the
Yes, makes sense. But the point is that although we Italian and Swiss people are very close from a genetic Caucasian point of view, however, in Basel, where Basel was the study center, the healthcare system is completely different than the national healthcare system in Italy. Okay, so so this is another important point. For example, this is the case when you are doing microbiology work, as we did in bronchiectasis in the EMBARC registry. When you are comparing Dundee with Milan and Barcelona, okay, you are putting the three centers together in a multi-center observational study, but Pseudomonas is more prevalent in Barcelona and Milan than in Dundee. So you are putting apples and bananas all together. So the final results could not be the right one. So in this case, what we do is a so-called sensitivity analysis. So we are asking the people to also show us the results of Milan versus Dundee versus Barcelona in order to see that individually they are not different. So if they are not different in terms of age, clinical characteristics, demographics, blah, 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 so you can put all these patients together and have just one final results. Otherwise, you need to show the data separately.
Okay. Fine. Okay. Was Senila asking a question? You were raising your hand? No. Okay. So for match studies, giving match criteria. So this was, we felt that this was not applicable.
No, this is not a match study.
Yeah. So regarding variables, clearly define all outcomes, which was mentioned, exposures. So in this case, I think this was community-acquired pneumonia was an exposure. So that was defined, how we define community-acquired pneumonia. Potential confounders. This was not addressed, we felt, and effect modifiers. So comorbidities, etc. I think they were mentioned. Diabetes, hypertension. That's what we could, and give diagnostic criteria for AMI, liver disease, etc. They were mentioned. So we felt that probably this potential confounders, and we were not sure whether this was mentioned. So we felt it was a no.
Yes. So you're right. We didn't put all the correct definition for important variables. We decided for sake of space to put only definition of outcomes and the definition of cardiovascular events. But this is not an excuse, because we have the online supplement, so we should have put in the online supplement the exact definition of community-acquired pneumonia, for example. So community-acquired pneumonia was defined as the occurrence of an infiltrate on chest X-ray plus CRP, blah, 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 occurring, blah, blah, blah. So this is important. We didn't put some potential confounders and some other definition. So this is correct. This was a mistake of the article.
So regarding data sources, for each variable of interest, give sources of data and details of methods of assessment. They describe comparability of assessment methods. So this was not applicable. So regarding the first sentence, what we felt that, though variables like length of stay, mortality is self-understood. So those were mentioned, but we felt that some things like, say, troponin measurement, how they have measured it, by what kit, and those probably were not mentioned. So I just wanted to ask you whether that is important, because to me it appears intuitive that it would be measured by a standard kit. But then again, if you are following this criteria, then it probably it appears that was not followed.
So you guys are right. But let me tell you this. If your study is a study looking at neutrophil elastase as a predictor of mortality in bronchiectasis, then I want to know everything about neutrophil elastase laboratory procedures. Everything, okay? Now, this is a multi-center study. So troponin has been was one of the biomarker evaluated, especially for the definition of acute myocardial infarction. And the level of troponin and the units of troponin might vary across centers. So it's fine for me not to go too much into the detail of troponin because it's not the biomarker of interest, but it's just one of the things that at the local level, according to local standard operating procedures, have been used to define a specific variables. However, if troponin was the biomarker of interest, I was keen to know everything you can tell me about troponin.
Right. So the next was next was bias. Describe any efforts to address potential source of bias. And so now here we had put a question mark because we felt that so just for an example, it was a multi-centric study. So we felt that people from different centers, as you said, the healthcare system is different. So that might have an effect on mortality, duration of hospital stay. So it was not clear mentioned upfront in the method that separate sensitivity analysis would be done for different centers. So we felt that probably this could have been a source of bias, and this was not addressed.
Okay, so this is another very important area when you are looking at observational studies, but also randomized controlled trials and so on. First, you need to have very clear in mind what are the most common bias in observational studies. Let me tell you the bias. The first one is the so-called selection bias. So the selection bias occurs when the selected participants are systematically different in terms of clinical characteristics among them. So for example, as I mentioned, if I select women in Milan, men in Dundee, young people in Mumbai, so this is a clear selection bias, okay? So the first one is to understand if there was a selection bias in the study. The second most common bias is called information bias, which refer to the systematic error in the measurement or in the misclassification either of the exposure or the outcome. So if I'm not able to, let's say, retrieve the information in the proper way, I'll go through an information bias. Let's make an example of systemic hypertension. If I recall the variable systemic hypertension in this prospective study, measuring blood pressure to all my patients and checking for drugs, is much better than looking at the charts and seeing systemic hypertension written there. Okay, so there might be some bias in getting the variables, in collecting the variables, especially if these are outcome variables. For example, mortality. Okay, so mortality, if I phone the patients and I talk to your wife and not your wife, and I talk to someone and I say, is your wife or husband dead? And she said yes or no. Is not perfect, but makes sense. if I go, for example, to a regular to an institutional local government where they can collect mortality very precisely for all the patients because this is the law, the collection of the mortality data is much better than phone your wife or husband. I don't know, you know, this is just a cartoon, just a general example, but also hard endpoint like mortality that you think, well, it's easy, mortality is mortality. No, because there might be patients lost in follow-up, you categorize as alive, but actually they are dead, you know? So this is important. And this is called information bias. There might be some important consequences for the information bias, because then if there is an information bias, the strength of the association of variable A and variable B is reduced, okay? Is reduced or is increased, but the reporting, recall, and observer bias has this important issue. These are the two most important bias that we can identify in the observational clinical research. Okay.
Right. Selection bias, and so selection bias was not there. Information bias, there was no, I think, mention in the study about how they have managed information bias. Would you agree with that?
Well, the selection bias, the selection bias, if I would have detailed in the online supplement all the specific we already talked about, the selection bias was low. Okay. Let me tell you this. There is a third important bias that is called confounding bias, which occurs when the statistical analysis does not account for all relevant effect. This is called either analysis bias or confounding bias. Okay. Usually we evaluate the confounding analysis bias in the statistical method section, not early in this part of the material and method section, but later on.
Can I proceed?
Yes.
Yeah, okay. So this was the bias part. Regarding the study size, we felt that how the sample size was arrived at, it was not mentioned in the study.
Yeah. Yes. This is wrong. Because I'm telling you that the prevalence of acute myocardial infarction is 2.3% among 905 patients. But if I would have run a multi-center study of 1 million people, maybe this 2.3% would have been 6%. So who tells me if the right sample size is 900 or 1 million? So this is the reason why we need to calculate, according to previously published literature, also the study sample size for observational studies. And this was another mistake, right?
Yeah. So so we agreed on that. Regarding the quantitative variables, we felt that you know, there was a mention in the methods in the statistical analysis that you know, the descriptive statistics were reported at baseline with continuous data expressed as mean plus minus standard deviation, and IQR for skewed data, and categorical data expressed as counts. So this was the mention which was there. If applicable, describe which groupings were chosen and why. So we thought that probably the grouping thing was not applicable to this particular study. So we felt that this was okay.
Okay. The statistical methods?
Yeah. Oh, statistical methods. Describe all statistical methods, including those used to control for confounding.
Not done?
Not done.
So you cannot evaluate if my study had a confounding bias or not.
Yeah, so later on, regression, etc. was mentioned. Regression, adjusted
Yes.
odds ratio was mentioned. So, but in the method part, at least that was not mentioned.
No, this is correct. And what else?
Yeah.
The other Animesh, the other important thing in observational study is the missing variables. Okay. Especially if this is a prospective observational study, because if it's a prospective observational studies, I'm expecting you giving less than 5 or 10% of missing variables. Okay, if it's prospective. If it's retrospective, I don't know. But if you are dealing, if you are putting your main message around the troponin, and I see that troponin was done in 25% of your study population, missed in 75% of the patients, so your data is useless. So this is the reason why in all the tables of the observational study should be always added a column with the number of missing patients for that specific variables. And usually there is an unwritten cutoff of 20%. So if you have less than 20% of missing variables, these could be accepted. If you have more than 20%, all the analysis you are doing with that specific variables might not be correctly interpreted. So missing data for observational study is something that I always request as a reviewer for an observational study. The other point is the loss to follow up, because it's important to understand the quality of the study. So if I have 2 patients lost in follow-up because they died, this is reasonable. But if I have 50% of my study population lost in follow-up, this makes no sense to me. Maybe because I didn't do my job correctly. I didn't follow the study correctly. I didn't have people that were able to help me in getting the long-term follow-up data. So all the data I have in follow-up are useless. Okay. So this is another important information you need to describe. The sensitivity analysis, for example, we talk about other cardiovascular events. So one thing is ischemic stroke, and one thing is arrhythmia. So maybe I would have done a sensitivity analysis looking at differences of patients with stroke versus arrhythmia. So this is a sort of sensitivity analysis, okay? Or a sensitivity analysis between 7 Italian centers versus 1 Swiss center, okay?
Right. So regarding the missing data, that was in 12C, so which we also thought that, we had not talked about, how many cases they were. So the discussion which we were having was that, if some patients had been discharged prematurely,
Okay.
is right. So probably those data, they were not, some patients who probably would have died within, say, 1 hour of their admission or 4 hours of their admission. If they died, then probably it would have been too early for all the echocardiography, etc., to be done, because in the criteria for acute myocardial infarction, there was a mention about using echocardiography or troponin. So in that case, the loss to follow up or the missing data was not addressed. That's what we felt.
Yes, this is correct.
And
let's move to the other session now.
Yeah, sure. Right. So regarding the participants, report a number of individuals at each stage of study, numbers potentially eligible, examined for eligibility, confirm eligible. So this was, we felt it was not done. I mean, we had talked about 905 patients, they were included, but from what number, denominator this was arrived at, that we felt was not mentioned.
Yes, this is correct.
And so 13B, I mean, as a corollary to that, I mean, 13B was also no. And use of a flow diagram, we could not locate it in the article or I think even in the supplementary, it was not there. So regarding this point, we felt that it was a no. Okay. Next, yeah. So next was descriptive data give characteristics of study participants, demographic, clinical, social, and information exposures and potential confounders. So this was mentioned. We felt that the different comorbidities, etc., was mentioned. Demographic, clinical was mentioned. Social was not there, but we were kind of hoping that this is again not mandatory for, mandatory for all studies. That they mentioned the social.
It depends on the research question and your what you want to address.
Right. Next was
let me stress, Animesh, the importance of the flow chart of the participants for the observational study. We know that it's very important for randomized controlled trials, but it's also extremely important and highly suggested also for observational studies. And in terms these and also the reasons for non-participation is important to understand the generalizability of the data, So it's important that specific flow diagram because I need to understand if your results could be applied to my population. Okay.
Fine.
Sorry, Animesh.
Yeah, sure. Thank you. So next was so indicate number of participants with missing data for each variable of interest. This was not there. Summarize follow-up time.
No.
Yeah, it was also not
this
there.
was mistake. I already explained you the importance of both concepts. So please do that.
Right. Outcome data, report number of outcome events, so summary measures over time. This was, we felt this was mentioned clearly. Give unadjusted estimates and applicable and if applicable confounder adjusted estimates and their precision. So we felt that we were just discussing that it was said that 2.3% had myocardial infarction, but the 95% confidence interval was not mentioned in that. So we felt that that could have been mentioned.
Okay. This is correct. This is absolutely correct. This is a more statistical kind of concept, but it's important always to give the estimates and to give the adjustment information and the 95 confidence intervals always because we want to always because of the concept of the generalizability of the data and the dispersion of the variables. So very important.
Right. So next was report category boundaries where continuous variables were categorized. So here interquartile range was used. So we felt that this was done. If relevant, consider translating estimates of relative risk into absolute risk for a meaningful time period. So here odds ratio was mentioned, which was we felt was a surrogate for relative risk, but absolute risk we were not sure that how could this have been mentioned.
Yes, these are more technical stuff, but very important. I don't want to go into the detail, but you can understand the importance of producing the right finding and collaborating with the statistician in order to improve the quality of your results. This is the message.
Right. So, sorry. So last was the key results. Summarize key results with reference to study objectives. That was done. Limitations. Okay. Yeah. Sorry. So limitations. Discuss limitation of the study, taking into account source of potential bias and imprecision. Discuss both direction and magnitude of any potential bias. So this was mentioned, but we felt that some parameters like it was a single continent study or it was a 2-country study. Probably. There was an issue with generalizability, so probably that was not mentioned.
Absolutely, Animesh, you're completely right.
Right. And give a cautious overall interpretation of results considering objective, limitation, multiplicity. We felt that this was done. Discuss the generalizability. Due to the same point, again, we felt that probably this was a query or this was a no. And and we could also not find the funding source.
Okay.
Like this. Yeah.
Yes, all these important points were not there, especially funding, because if there was, for example, a troponin company sponsoring the trial, there might be some conflict of interest in there. So think always about that. So you guys did a wonderful job. Thank
so
you.
Our conclusion was
okay.
it was a very well-written study, and that was first conclusion. Second was that the Strobe criteria, they're very stringent. So
yeah,
based on that, some points were missing. That's what were ultimate.
Well, I thank you so much, because the jury was nice with me, but let me tell you that all the points you identified are very relevant. Oh, let me get this call, please. So apologies for that. So let me, you mentioned the Strobe checklist. So the Strobe checklist is the Bible. Okay, so I was wrong. The Strobe checklist is not too much detailed. Is how the observational study should be conducted and reported. Okay, the most important message is, I think that some of you knows me very well, and I think I have a little credibility in the field of respiratory infection and pneumonia. And you think and you understand that the European Respiratory Journal Open Research is a nice journal, is not crap. So although I am a credible person, and although this paper has been published in the European Respiratory Journal Open Research, still there are plenty of unresolved issues that do not feel, I would not, that can make not you feeling confident in accepting those findings. So the name of the author and the journal where the article is published not always guarantee the quality of the data and the quality of the study. Very easy for you. Apply, in this case, the Strobe, tomorrow the Consort, and then the Prisma checklist. See, evaluate the study by yourself, and you will find that a high percentage of papers published in PubMed are of very, very, very low quality of evidence in terms of methodology and result. Okay?
Yeah.
So guys, thank you so much for this great afternoon, and you did a very nice job. And any question you have, you can email. You have my email address, so feel free to do that. And I think that you are going to enjoy tomorrow more than you enjoyed today. So with Professor Effler, you will talk about randomized control trials. So nice seeing you all on the web today. Okay.
Thank you.
Thank you very much.
Bye bye.
Bye bye.
Bye bye.
Bye.